Hello, young people, students of psychology. Good to have you here and good to be here. It's been a while. I hope you were missing me and I hope you didn't get too bored when I wasn't around. And today I would be. So if you feel not that you're going to get bored because you have one of the funniest and the most best one-liner doctor in our program, that's Dr. Kedar Tilve, and you will have Sud Sahab also. So you have a unique combination today of two people speaking to you. So you're unlikely to get bored. Otherwise, you can just reach out to me. Right. I've also told our two experts that they should be giving you your regular breaks. The breaks are very important. And as you all know, I'm the chai person of this program. So it's the chais that have to be taken care of. I've already told Sood Saab that first tea will be served at 4. One tea will be given right now. Second is served at 4 and then the next at 5. So Sood Saab can carry on. And we made sure that Kedar is going to be well taken care of as well because he will have to take care of himself by himself because I am not going to call the grandchildren and tell them to take care. So Kedar will have to do his own thing, right? So today, interesting one. I hope the last few days also you've been getting a good exposure and you're learning these various aspects. If there's anything on your mind from the last few days before I call our colleagues, you can type in there. Your attendance link has been. Yes, those jam biscuits. Good, you reminded me. I just had one and I again forgot and I called them jam and then I was told it is Jim Jam. But I had them. I've had my two biscuits. I've had my chai and then the chai of Sud Sahab is going to be served very soon. Okay, so let me now make you meet our experts one by one, young people. And since you don't have questions for me, which is a relief, right? We should ask all these questions to Dr. Kedar Tilve. He's looking at about 1,200 questions. And if you have any questions which you want to later on say, then stuti.sood at fortishealthcare.com will answer you all these questions that are left today over the next few days. And feel free to send us 1,000, 2,000 mails is something that we are comfortably here. Good to see you all too. And let's meet expert number one for the day, the very ultra well-known Dr. Kedar Tilve, the very big name, renowned psychiatrist based out of Mumbai. He looks after all our Fortis Healthcare mental health programs from Mumbai, is an advisor on our Adayus board, is an advisor on some of the upcoming projects we have, exceptionally well known, a media personality, writes a lot, and like I said, is famous for his one-liners as well. This is a funny person, I must tell you, right? But more importantly, here he is not there because he's funny. He's here because he is very um, well trained, and more importantly, in this particular field of health psychology, he's now been working for over a decade. Working in the field of consultation liaison psychiatry and psychology. So he brings that aspect of the where psychological well-being and mental health merge in with the non-mental health areas of health. And that's something which he's exceptionally good at. So that's going to be Kedar Tilve sir for you. And we say hello to him. So say hello, Dr. Kedar Tilve. Welcome from
Good,
Mumbai, where it is
good
apparently I'm
afternoon. Good
raining a
afternoon.
lot, and I'm hoping it will rain a little bit in Delhi as well. So that's Kedar Tilve sir for you, right? Certificates will come. We are slow. We will get you the certificates, but we are a bit slow. And then our next expert is Sood Sahab. So the Sood will come in before I leave in. I've been instructed to leave this room at the earliest, and I've been told that tea should be served on time. Otherwise, Sood Sahab gets very upset. And I'm just going to send a message to Dr. Kedar Tilve's home as well, that Kedar Tilve will make tea for himself when he has time and he'll serve himself. So at that time, Sood Sahab will be served tea by the chairperson, and Kedar will be serving tea for himself, and you all can take a 2 to 3 minute break. That's Sood Sahab, also known as Tuti.Sood at fortishealthcare.com, is a counseling psychologist with us, comes with tons of years of experience, I'm told, and has been working in the field, like she says, especially with young adults and young people. and has worked earlier in health psychology before moving on purely to the counseling clinical bit of therapy. So she is going to, with Dr. Kedar Tilve, take you forward on this. You do unmute yourself. You do share some thoughts. I haven't seen a bit of unmute from you guys. Come on. Give me a bit of unmute in the evening when you are done. Let's talk mental health. Let's break some stigma and barriers, and let's have a conversation on health psychology. As I go because I've been asked to go. Otherwise, on popular demand, if you will say that you want me around, then they'll not have a choice, right? But right now, they have asked me to go out. Just don't tell them that I told you that they asked me to go out. Yeah? But since what can we do? Yes, good to see you too. I'm going to go and Sud Saab will sit here. Sud Saab and Tilwe Saab are now going to take you on this journey of health psychology.
Good afternoon, everybody. A very warm welcome. And Dr. Parekh has given a rather beautiful description of what we're going to speak about today around
You
health
called it
psychology.
disruption. It was not disruption.
You know
It
why.
was description.
You
I'm
know
not
why.
disruptive. I'm very
Why.
descriptive.
That's the difference between disruption and description.
It was
For
a
you.
Freudian. Right. So, health psychology, our topic for today. And so the interface of health and psychology together is what we would be talking about, and how health and psychology come together, how psychological factors play a part in illness, and how is it that we need to cater to those aspects that are contributing factors in a clinical setting is what we would be looking at. And as a part of this session, we'd be looking at different verticals of health psychology. Some of those verticals are more clinical in nature, which Dr. Tilve would be running you through, and I'd be running you through the psychosocial aspects of health and illness put together. So, without further delay and bidding you farewell, sir, we would be starting our session for today. The very first thing that we start with is understanding health. So, before I actually start talking about what health is, I'd like all of you to put your thoughts around what health is and what you understand from health. You've had a couple of sessions that you've been attending. So just help us understand what is your understanding of health. When we speak about health, when we put out that term health, what is it that you understand? So let's start with that. How about you put in a little bit of shares here or there? So if we were to say that I am healthy, what are some things that we're looking at when we talk about health? Good immunity, very good. Anybody else? Mind, body, well-being. Brilliant, Ria. Thanks for putting that out. Well-being, great. All right. General well-being of the human being. When we speak about health, let's understand that health is a complete state of physical, mental, and social well-being. And it's not merely the absence of any disease or infirmity. That definition particularly talks about how health is something which we need to look at from a 360-degree vantage, something which is relevant from the point of view of physical health, mental health, and social well-being. So just because you do not have any illness or there is an absence of disease, you cannot say that you're healthy. Now that is the first learning for you here, right here, that if we do not have any illness or if we're free from any disease, that alone does not guarantee that we're healthy. So it's a state of complete physical and social well-being. Why are we emphasizing talking about health so much here is for the simple reason that when we speak about health, a lot of us, a lot of times, we try to focus on the physical aspect of health, which is where the mental and the social well-being part gets compromised. It is something which is very conveniently overlooked. So here we learn as students of psychology and as students that health is not a mere absence of diseases. It's not something which entirely focuses upon physical health, physical symptoms, right? And as we learn, as a part of this session, we would learn how mind and body are one. That is the foundation of health psychology, right? So is there anything that you'd like to add to this, Dr. Tilve, perhaps in terms of health from your own medical vantage?
Well, Well, what I would like to point out is that the definition was adopted by World Health Organization after some time. Initially, health was you have to be healthy, you have to avoid diseases. It went to no, you have to be fit and healthy. You have to be optimal version of yourself. So till I think 2000s, we are not very comfortable with the idea that spiritual well-being, mental well-being, social well-being include hoga. So a lot of people still associate health with gym kitna kiya. Okay, and that is fine, but you have to understand, and as we're going to discuss in the health psychology forum, that it is not only physical gym but it's also mental gymming which matters, and we'll figure out how to beef that up as we go along if we get the chance. But health is a physical, mental, and social well-being. This is a new concept, and it is not a very old one. So remember that when we talk about health psychology, a lot of things that you guys will take for as assumed stuff was not actually the case. It took a lot of people working very hard to get the World Health Organization to understand that this is how it should be and not just physical illness. Yeah. So we have to be thankful for the little things done by many people over a lot of years to arrive at this conversational topic. Yes, that was my two bits.
Thank you, Dr. Kedar. So moving on, when it's about mental health, that one domain of health that we largely tend to ignore, and something that I'm going to start by saying that you cannot define health without mental health, right? That is something that all of us need to imbibe by now as students of psychology, as students, right? Attending this session today, that there is no health without mental health. And the next time somebody is trying to define health without mental health, you correct them. You break their bubble, right? This is why we're talking to you about health psychology today. So, mental health is a state of well-being in which an individual is realizing their own abilities. They're able to cope with the normal stressors of life. So, whether it's you, whether it's me, whether it's Dr. Kedar, all of us will go through stress. These stressors can vary. These stressors can be different for different people. These stressors can be, again, vary in intensity. What accounts for stress for somebody does not count for stress for somebody else, right? And more than the nature of the stressor, it's also the response that we have towards that stressor. So when we talk about mental health as a concept, it is very important for us to imbibe that it's a state of well-being which enables an individual to look at their capabilities, how they look at their own abilities, their own resources, their own strengths, their own weaknesses, all put together, right? So as to work productively and to contribute to a sense of community. So you're appraising your resources, you're appraising your abilities, you're able to cope with the daily stresses of life. Daily stresses can look like traffic, can look like deadlines, homework assignments, maybe like a fight with a friend, with a peer, an argument at home, perhaps something which went missing at home, something that you did not like, and a lot of other things of this. Now, all of those things put together account for daily stressors. How you cope, what your ability is, how you inculcate that, and how does that help you, and how you take it forward is all covered within the purview of mental health. So, what we need to right now pay attention to is that there is no health without mental health.
Yes.
Mental health is mere that it's more than the mere absence of mental disorders, is also something which we need to reflect on. That it's not that you may struggle with some mental is there an echo or no, it's fine. I thought there's an echo. It's fine, right? All right. So mental health is more than the mere absence of mental disorders, right? So there may be a host of disorders that some people may struggle with. But when we talk about mental health, that also goes beyond the absence of mental disorders. There are a variety of socio-economic, biological, and environmental factors that play a part. So, all three things, when we talk about any mental illness, there are three factors at play: biopsychosocial factors, right? Biological factors entail the genetic makeup, the neurochemicals, right? So, that is where pharmacological intervention comes into the picture. So, you have a genetic framework, your height, your weight, your eye color, all of those things are very genetic in nature. The same way there is a genetic predisposition for illness, and it can be for any illness. It can be for diabetes, it can be for hypertension, it can be for any mental illness, anxiety, depression, anything. Then there are psychological, psychosocial factors. So your own personality, how you cope, your understanding of your emotions, the level of support system that you have, the resources that you have. So all of those things are important determinants of mental health. It's an integral and essential component of health which cannot be ignored. Mental health awareness is directed towards actually imbibing the concept that there is no health without mental health and that we need to take that into account. Further on, mental health as a concept is so crucial to an individual's well being, and not just in the capacity of an individual, but as a part of a collective. So, when individuals are healthy, communities are going to be healthy, the society is going to be healthy. And we don't just define health in terms of absence of illness, but something which looks at positive coping, prevention of illness, and other concepts that you would come across as we move on in this presentation. So, yes, Dr. Kedar.
Just go back. There is one thing we need to understand about the biopsychosocial model. One way of looking at the biological aspect is genetic predisposition, but what we are coming to terms with is genetic predisposition. The chances that you will get a mental illness is higher if you have a genetic basis to it. What it also means is there has to be a social stress, a psychological stress for a biological dysfunction to occur. So, biopsychosocial model works both ways, and we need to remember this because it's a grain of hope for patients whom we are treating. And essentially, what I think it was Freud who had said, ki we have to use psychological terms till we find neurological terms to describe what we are seeing. So everything will be biological at a certain extent, but there is very much an interference that is played by psychological and social situations. And if you look at the circuits which are drawn up very well in CTP and other places also, you will realize that psychological and social stresses actually have a place where they work in that framework. So remember, it is predisposition, not necessarily a fact that any person who has in genetic predisposition will get it. And secondly, it is a combination of all the three. So it gives you a sense of hope, and it gives the person a sense of life to look forward to if you're getting treated for a mental illness. It's not A plus B is going to equal C. It is going to vary from person to person. Yeah? And this becomes very important when you look at something that all of us experienced in 2020, because earlier I used to have to talk about what collective well-being was, what the sense of belonging to a community meant. But since 2020, we don't have that concern. We all know what all of this means. We just have to see how it translates to the functioning that we have. Yeah. Thanks.
The intersection of health and behavior, health psychology. So, our topic for today, health psychology, looks at the coming together of health and behavior, how our behaviors impact our health, how the choices that we make have implications on our health, on our physical health, on our mental health alike. So, that is what health psychology focuses on. So, there are a couple of questions that we have for you. Something for you to reflect on, something for you to understand this concept better, and for you to relate it to your everyday lives so that there is some sort of learning. There is some learning which is coming from reflection, and this becomes applicable. The whole idea of talking to you here is to help you think, broaden your perspectives, so that you're able to question, you're able to ask yourself these questions, which are very important questions, which are missed largely, right? So, why does one use substance despite knowing its harmful effects? All of us know that substance is bad, it's injurious to health. You and I, all of us put together, have this basic understanding of how substance is going to cause harm to health. But why is it that people tend to resort to substance? That is
I have
something
an, I have
other
an
reflect.
interesting question, Stuti, to ask all the people who have joined us.
Yes.
Before talking about why we use substances despite harmful effects, let's just ask them what are the substances that you know of?
So we have a couple of responses here in the chat box to divert
Well,
their
it's
mind.
just represented instant gratification, inability to resist the impulse of compulsion of the substance. Yes. Alcohol, correct. We are talking of alcohol, nicotine. What are the other substances? Oh, okay. You guys go high octane very quickly. Cocaine and amphetamine came up immediately. So did marijuana. Thank you for that. Otherwise, I would have lectured you for 10 minutes on the fact that cannabis is a psychoactive substance. Drugs, yes. Gambling, well, it's not a substance, but we can see where you're coming from. Opioids, yes. Very important when it comes to health psychology. Opioids, perfect. Now you guys are getting into my sort of area. Caffeine and chocolates. Anushka and Creative Bits, thank you for pointing it out. Because I can tell you, if you're going to talk about health psychology, we are just not going to discuss alcohol, nicotine, and other stuff. We are going to talk about the small things. All right. Okay, stop, guys. You're scaring me with your knowledge of drugs. All right. But yes, I was asking you this question to get coffee and no, perfect. Sugar has come up, coffee has come up, and what else did I miss? Chocolates also came up, and these
Yes.
are relevant because we are going to be talking about this and where we can intervene to improve a person's overall health. And yes, thank you. Prescription drugs, by the way, are not drugs of abuse. They are only drugs of abuse if you don't allow the person who is prescribing it to supervise it. खुद के डॉक्टर बन जाओगे तो फिर वो अब्यूज हो जाता है. Yes, Chehel cigar in so many hours is still a cigar, as Freud had pointed out. Tea, that's interesting. By the way, green tea and green coffee, or sorry, green tea and what is it, coffee, or pure black coffee? Yeah, if I'm not mistaken. I'll give you a small hint of why I'm taking this question out of Stuti's area and talking about it. Because coffee can produce a syndrome when taken in excess. And I made the mistake personally of thinking that kava had to be taken like black coffee. और ब्लैक कॉफी नहीं, ब्लैक टी. तो मैंने कावा को उतने ही स्ट्रांग बनाया जितना हम टी को बनाते हैं, राइट. एंड इट लेड टू एन एक्सट्रीम एंजाइटी रिस्पॉन्स. So one of my patients had told me once ki, boss, if you're going to object to green tea and black coffee as well, what is a substance? And the answer was anything when taken in excess which will cause some sort of a unhealthy response. All right. Chehel, you are absolutely right. Screen time and playing games are not there yet with substance, but we can include those in behavioral addictions. This is a conversation for later. When we talk of substance, it is any psychoactive substance which is likely to harm you. All right. So going back to Stuti's question. All right. Going back to Stuti's question, why does one use substance despite knowing its harmful effects? Why do you tend to use alcohol, cigarettes, despite knowing their harmful effects? Answer away, guys.
So, since you've already shared a list of substances which we were trying to gauge that qualifies for, substance which tends to be addictive in nature, as Dr. Kedar also spoke about, how about all of you reflect on this question and try to answer it for yourself? Because we have a couple of these questions coming which we would like you to think about so that you're able to relate to this topic better, right? So a few responses that we got: distraction, to cope, to keep mind off things, to somewhere deal with stress, right? A couple of responses that I'm picking on from the chat box. So these are some peer pressure, of course, all of these things put together. And when we look at all of these things, is it safe for us to come to this conclusion that sometimes substance is used for coping, sometimes substance is used as a means of avoiding difficult feelings, difficult emotions, or the stress that we may be going through in our everyday lives? substance by and large has addictive properties. Let's not forget that, right? There is a sense of tolerance which it entails. Like your body, if it is used to a particular substance, consumption of that substance over a period of time, whatever effects that you would get after consuming that substance, there is a tolerance that your body builds, right? So that is also an aspect that we need to take into account when it's about substance. And a lot of your time goes around procuring that substance, which also leads to impairment in your everyday functioning, right? When we go to the next question, I'd like to ask you, why do some people tend to resort to food to relieve stress? Is this common? Do you think people tend to resort to food?
Yeah, you're asking me, then the answer is yes, yes. Whenever I'm stressed, I'll go and eat some ice creams in the fridge.
Yes, all
Mhm.
of us have to
Yes,
some or the other.
luckily my dog accompanies me. But yeah, anyone who has never done this, who has never actually gone in
Gone to
stress
food.
and yes, gone and binged on ice cream or makhana or whatever it is. Yeah,
We have
happens.
people who've not done this. That's actually a very interesting question from Dr. Kedar's side. We would like to know if there are people who've not done this, because this
Yes,
is
and
something
we would
interesting.
like you to unmute and speak to us about it because
Yes, right. So stress eating is common, emotional eating, sudden dopamine release. All right, Dr. Kedar, they're throwing terms at us, and which is
oh
good to
yeah,
see.
yeah. Wait. I'll throw a term now. I'll throw a term known as night eating syndrome, and I'll scare everyone saying that this is one of those things for further review in DSM. I don't know whether they reviewed it further, but there was actually a night eating syndrome जिसमें they were going to figure out कि stress की वजह से जो हम extra we eat is it an disorder. But it's interesting, isn't it? So many people can share so much experience, and we can talk for 3 hours on nothing but what we ate at night, with whom, watching what. And I can tell you, yes, my dog somehow senses this and will come down with me just to see if she can get a biscuit out of me.
How
But
lovely.
yes, lovely
Right,
depends. Yes.
right. So
This is
it's
someone who
important
said, not me. Huh? That is wonderful.
yes, and it's safe for us to conclude that it's not just confined to us humans, right? It transcends all boundaries. Food as something that we use to relieve
Yes,
stress.
apparently, Stuti, canines tend to do this more at night also.
Oh, wonderful. That's a fun fact.
Really, tigers and lions go out in the night to relieve stress. But yeah, no, on a serious note, it is found that stress eating is something that is common. However, humans tend to do this more with high caloric value foods. Animals will not do this so much. Animals will tend to do this with low caloric value food, just to relieve physiological distress. But yes, oh, someone. So we are back to no one, because the person has just pointed out that that person does not stress eat; she stress shops. Happy for you, because it means you have enough money to stress shop.
Right. So moving on, do you think bodily complaints can also be explained by psychosocial stressors? So whatever we may be going through physiologically, or if there are symptoms related to the body, frequent aches, frequent pains, anything which has to do with a manifestation in your body, do you think it has psychosocial basis? Think about it. Could it be a result of stress? Could it be a culmination of a lot of, let's say, in conventional terms, unresolved conflicts, anything which has to do with perhaps stressors which may not have been dealt with and distress? So, right, there is a unanimous yes there. Dr. Kedar, I'd like you to take this forward and perhaps help us understand
Yes.
a few of these questions.
So we're going to talk about health, psychology. Then I have to ask you some pertinent questions. You will understand the importance of this as we move forward. Okay. So I have this question for you. Why do some people miss the daily dose of medicines? Okay. Think about this. But since we are all right now very much into answering questions I'm asking you, one question for all of you. How many of you have managed to complete a course of antibiotics successfully? All right. And how many of us have actually taken the course of 5 to 6 days, then forgotten to finish the seventh day medicine? Yeah. Yeah, yeah. It happens to everyone. It happens to everyone. And the funny part is, it is not only painkillers. So not only antibiotics. It happens to painkillers. It happens to antacids. Doctors have a funny way of prescribing. You will take some medicines half an hour before, half an hour after. You will take it, or 1 hour before food. You will take it not in combination with each other, not with coffee, with tea, after food, with food. There is a medicine which has come up in psychiatry which has to be taken when you are eating food. So it creates a lot of confusion. But how many of us have ever finished a course of antibiotics or missed finishing a course of antibiotics? And you need to answer this for one simple reason. A lot of the chronic illnesses are dependent on you taking the medicines regularly. I mean, I am a psychiatrist, so mental health का concern जो है उसमें antidepressants and antipsychotics have to be taken on a daily basis, otherwise the effect goes off. I'm not only talking of mental health, I'm talking of TB, I'm talking of HIV, I'm talking of skin infections which will rise and remit over a period of times. For a lot of them, they have to be taken over 3 to 6 months, and people simply forget to complete the course. Adherence is a huge issue. Okay, so you need to remember this key as a health psychologist or a person working in the medical field. If you can tackle adherence as an issue, get the person to finish the course that you have prescribed. It will take care of the commonest reason for relapse. It is actually there in Maudsley's prescribing guidelines, which we follow very religiously to figure out how to prescribe. That if you can take care of adherence and compliance to treatment, half of your concerns with the medicines will reduce. Okay, but it happens very frequently, and the funniest part is, and all of you will now realize what I'm saying. If someone else gives you the medicine, okay, you will complete the course. The person giving the medicine, who is given the responsibility of supervising the medicine, will actually ensure कि आपका एंटीबायोटिक का कोर्स भी खत्म होता है और आप पेन किलर्स भी बराबर से लेते हो. And this invariably happens. It doesn't matter who is doing this. Remember, it can be the nurse in the hospital, it can be your mother, your father, your sibling, it can be your girlfriend, boyfriend supervising from afar. Okay, but if someone else is given the responsibility of finishing your course and supervising your course for you, just giving you a reminder, the course gets completed. All right, couple of concepts that will come to the importance of social support in health psychology. All right, and even more important, just in case I forget to mention this, it forms the basis of a very very fine intervention, wonderful intervention, which came about in the realm of public health, and it is known as directly observed therapy supervised, TOTS, used, if you guys don't know, for COX or TB. And it helped reduce the uh, the non-compliance rates. It helped reduce the burden of the disease and improve the prognosis by leaps and bounds, so that now drug resistant tuberculosis patients actually have to go and collect their medicines supervised. It transcended a lot of social and psychological factors. Yes, Deepika, dots in TB, you are right. And it is someone who is not related to you, who is very strict, a nurse or a physician, who will tell you कि हाँ ये हफ्ते का ये पैक है पिछले हफ्ते का दिखाओ, and it works well. So health psychology has very very interesting and different offshoots which we'll look at. But just in case I forget this, remember these are the examples. And why do some people miss their daily dose of medicines? Well, we'll discuss this when we move along as well. Next slide, please. Oh yes. Why do some people binge on sweets despite having diabetes? If you can't hear someone sniggering behind my back, that is because I am in Bombay. I am at my home. We are having torrential rains, so people are working from home, which means that my wife, who is a software consultant, is sitting and doing her job by herself. And she just heard the question, which is relevant because I do have diabetes. And like I was telling you, I do binge on ice cream in the night, so the sniggering was actually her. By the way, since we're talking about this, I might as well tell you I am in Bombay, so we'll be joined by Rain, by my wife, who hopefully has her headphones on, by my dog, if he figures out that there's an AC on, and by my kid, who will just come for the sole purpose of ensuring that rather he makes himself visible. You are right. Okay. On a serious note, craving, yes, and like Deepika is pointing out, dopamine release due to a high rewarding factor of high calorific nature of food, but simply put, craving, yes. And you need to understand, when we talk of health psychology, the idea is to show them how to control the cravings. Why do some people binge on sweets despite having diabetes? Because it is so intense that people will actually forget that it's a slow poison that they have, and they will go for that instant gratification, which is more problematic. So impulse control is essential. Okay. And luckily enough, again, so that I might forget this later, mindfulness techniques will help you reduce those cravings. So these are relevant questions. These are questions which we see on a day to day basis. And if we are going to call alcohol use as a biological disorder, then you have to understand that your elderly people in the house, when I'm saying that, I have to remember that I am myself a diabetic, so I am not that elderly, but people who have diabetes and they go for that sugar rush and binge on that sweet, for them it's actual physical craving. So if we can not trivialize that and understand this and help them cope with it better, show them how to go past this, that would ensure not only compliance, that would also ensure the quality of life improves and the overall prognosis improves. Yeah. Oh yes, Anushka, it is denied. I agree with you. My wife is hearing me. I agree with that completely. Sugars are denied too much to diabetics, though with a very good heart. Yes. But sometimes the craving is in craving. Anyways, we'll discuss impulse control later. So, next slide, please. All right. My sister is an anesthetist. So, one of the first books that she read, she showed me the first page of that book. And the statement that is there in this PG book of anesthesia is, there is no greater calling than to alleviate or help reduce pain. But therein lies the problem. बहुत बड़ी समस्या है. How painful is the pain? Okay. Yes, we have a doctor answering immediately. Pain is a subjective feeling and depends on the tolerance and extent of trouble. But there is one problem. It is subjective to the extent that I, as a person, will not tolerate a dentist, but will go around with a fractured hand and a cyst in my shoulder for 2 months. I will actually write a paper. My second year MBBS, I went through an accident at the first preparatory Livka day. So there was a big tear here and a break here. So there was a screw and there was this thing wire put in, yeah, and it was hurting, and I still managed to finish my paper because I could tolerate the pain. But usi saal, a dentist had tried to perform a root canal on me and I could not go there and finish it. Yeah. So my question is this: if I asked you how painful is the pain, how much of it would be subjective and how much of it would be objective? There is a pain scale which says ki you rate it from 0 to 10, but then if you ask me, I would say ki dental pain is somewhere around 9, but hath tuta to I'll rate it around 5 or 6. Varies from person to person. Remember this, it has got something more to do than just pain, which comes through nerve endings and the entire, yes, visual analog scale, correct, Deepika. That just comes through your entire nerve endings and how it is seen. It depends on what your experience is, Depends on what your anxieties are. It depends on how predictable the pain is and what you are going to be able to do about it. There are amazing stories in psycho-onco wards where you go and see kids tolerating pain that adults cannot. There are amazing stories in Cox patients, and I'll talk to you about why I'm saying Cox again and again, where they will go through painful procedures in spite of not having the resources because there is a will to carry on. I'm not saying that the mentality of the person is the only thing it matters. Okay. Otherwise, my sister will come and beat me up. I'm saying it is one of those factors. It is one of those important factors. And we need to understand this because more and more we are starting to realize that the subjective expectations that an patient has will color the treatment and the prognosis of the person. All right. Chahal says, "Where there is we, there is a well. There is where there is will, there is a way." Yes, and you are right. You are absolutely right. Today we are going to tell you how to develop that will in a person whose dopamine, whose endorphin systems are so fired because of the biological illness that they can't carry on. That is health psychology in an essence. People ask why I do this, and the answer is simple enough. It is because there will be times when you improve the quality of a life so much that they just open up and carry on from where they thought it was impossible. Recently, I had a patient in my OPD who had chronic pain, so in fact, somatic symptom pain disorder. Went to all physicians, did all interventions, could not be helped, but never came to a psychiatrist. And all of us can guess why. It was because अगर मेरे पास आओगे तो मेरे दवाई की वजह से आदत लग जाएगी साहब आपकी दवाई की वजह से आदत लग जाती है डर लगता है 9 months into the treatment the medicines are done he is happy his anxiety is still there but it is at a level that he can manage. He comes from 4 hours away from where I stay, and he traveled in this rain along with his wife yesterday. And to give you the significance, day before yesterday, Bombay was flooded. Okay, so he still took the risk, traveled with his wife, and the wife said thank you because for the past 16 to 17 years, their entire resources, their entire focus has been on how to alleviate his low back pain. And all it took was the medicine and the confidence of a brother to say ki, all right, if nothing else is working, try this. He will take off the medicines. All right. So yes, we'll discuss the aspects as we come along. But let's just move to the new slide. Otherwise, okay. So do you want to talk
So,
about this one? Or should I talk here?
yes, Dr. Kedar, I'll start speaking about health psychology when also all these questions that we spoke about and where you got an understanding of how there are behaviors and how they impact our health, the choices that we make, everyday choices that are there, right? And what lies in the background of those choices is what falls within the purview of health psychology. So, as health psychologists, we examine how the biological, social, and psychological factors influence health and illness. If we speak about this in the context of chronic illness, an illness like cancer, right? So, how patients struggling with cancer, right? What are the psychological factors which can aid the treatment process? Vis-a-vis, at the same time, what are some things which can hold a person back, which can affect compliance, adherence to treatment? So where you were talking about whether, this whole thing of where there is a will, there is a way, how much of that holds true? And is that the only determinant? Right. So the answer can't be so linear. It depends on a variety of factors, the nature of the illness in terms of, what the illness is, the prognosis, right, the course that it has followed. At the same time, factors like psychological factors, which I'd be speaking about. So when it's about psychological factors entails our personality. So who we are, how we think, how we feel, and how that impacts our behavior. falls within the purview of psychological factors. Now, think of it like this: two people, similar demographics, same gender, same onset, same age, everything like all other variables, if we say that those variables are fixed, the response to treatment would be very different. What is it that explains that? So if you look at various things like demographics, like gender, like other things in terms of illness, the nature of the illness being somewhat similar, but how is it that the treatment response or the treatment outcome ends up being different? One person responds better to treatment and another person is not responding that well to treatment. What is it that explains that? So that is what health psychology tries to look at, right? So all factors which pertain to your biological system, the social and psychological factors which act as protective factors, which can help aid the treatment process, right? How is it that you can improve your choices, you can improve your behavior, you can consequently like improve whatever you're struggling with? So how is it that your thoughts are connected to your feelings? How is it that those feelings impact your behavior is what we study, right? So how and what you think about whatever you're going through. Now, this is something which we will also take up as a part of stress and illness. So your appraisal of a situation, your thoughts around that situation, how does that make you feel? How much do you feel in control of the situation versus how much do you feel you have the resources to cope with that situation, to cope with the illness, is to a large extent that it determines what the treatment outcome is going to look like, as Dr. Kedar was talking about a while back, right? So, individual differences play a big role. And we, as health psychologists, look at those individual differences. It's very important to take into account those individual differences which separate us from each other. So, health psychology also focuses on promoting health. So it's not, again, picking up from what we spoke about a while back, it's not the mere absence of disease, but how is it that we can promise better health outcomes? So, what are some positive behaviors which can be adopted to prevent illness? And how is it that healthcare systems as a whole can improve to promise a better quality of life? So, if you talk about any multi-speciality hospital or let's say any healthcare system, right? How is it that we would enable proper care without inculcating mental health care, right? So whenever you go for a preventive health checkup, usually all your parameters are checked, right? So those, do you think those parameters alone can promote health and well-being? That is a question for you to answer. Until and unless we include mental health as a domain, as a vertical, which is an integral part of health, as a preventive measure, it also helps us look at what are some things that people are at a risk of developing, what are some illnesses which are prevalent or more common during a particular stage of life, right? So if somebody is talking about, let's say, forgetfulness, issues with memory, and this person is around the age of 15, 16, you can't call it dementia, right? So we need to understand it from a broader perspective that there are some illnesses, and here I'm talking about disorders, mental disorders specifically, that there are going to be specific disorders which are going to be at specific stages and specific age related concerns are going to be there. So you wouldn't have a case of dementia in, teenage or early adulthood, or, if it's not old age. So, what is it that describes that, right? So, all of those things we need to understand. It also studies the factors that influence the choices we make about health. So, again, going back to those questions for reference, the fact that why do we still, resort to substance? Or why is it that we know that, okay, we're resorting to sweets, but there is diabetes? So, all of those things are linked to what we're talking about here in health psychology. So, health psychologists, they work in close collaboration with other medical practitioners to provide whole person healthcare. That is important because when we talk about whole person approach, we're looking at all domains of health and not just one, which is physical. So, what is it that explains frequent pains and aches? As Dr. Kedar just spoke about a patient, a case example, where this person had gone to various physicians, right? And it's not easy. Understand the psyche of a patient where you feel helpless, where you feel stuck, where you feel, that it's taking over, you feel anxious, you feel overwhelmed, and that is taking a toll on your mental health, right? And you continue to struggle. That continues to impact your everyday life. That continues to impact your quality of life, right? So these are stories which are inspiring stories. These are stories that we come across each day. And there's so much misinformation and stigma around mental health that people don't reach out for help. Depression, anxiety have seen an increase ever since COVID. 25% of global increase, which is not less. It's not just 25%. It's a big figure. It's an alarming figure. 25% of increase in anxiety and depression. It's that common. And
I'll,
especially
I'll,
after.
I'll scare you more, Stuti.
Yes.
Um, Depression was supposed to be 1 in 4 people, okay? Which is fine. The earlier nuclear family used to be 4 people. Post COVID, it will now become 1 in 3 people, which is the current family now. So 1 in 3 people will experience depression or anxiety symptoms at some point in their life. That is the impact that you are talking about. It's just not 25%. It is a situation where we are now going to have to deal with this at a daily basis, and that's the 25%. This is what she's trying to tell you guys. This is what she's trying to harp on here. It is much more than just percentages. This is our day-to-day functioning. So if you wanted to look at it, one of the things that I found very easy to convey to people is 1 in 4 people would experience depression or anxiety. That figure became 1 in 3 post COVID, because remember, the numbers increased and the family size reduced. But a very interesting study came out, I think it was in NIMHANS, which said key of the people coming to the hospital, 1 in 2 patients will go through depressive or anxiety features. And since I know that Stuti doesn't seem like the person who's going to get depressed or anxious, I'm going to tell you it's probably going to be me. In fact, we'll discuss a case scenario where my anxiety overwhelmed me into a situation which I'm not very proud of, but I found a way around. So, this is the impact it is having on the overall parameters, and it is 1 in 2 for people visiting hospitals. So this is what the stats are looking at. Yeah, I'll let you carry on. So I just thought I'll put the numbers into perspective.
Absolutely, absolutely. And in fact, that reinstigates the fact that these are not just figures, right? That's the whole point. That it's not just a figure for you and me to talk about. These are lived realities of people. This is where people find themselves to be helpless. This is where hopelessness takes over. This is where, because of stigma, because of misinformation, anybody and everyone who can access help and treatment doesn't do so, and a life is lost. So, this is a reality, and that's why we're talking about it right now, right? So, the mind body connection, the basis for psychosomatic medicine, something that is the foundation here for us to talk about. So, if we assess different schools of thought, there is dualism and there is monism, right? So, when we talk about mind body connection, we're looking at how it's integrated, how they're not separated, right? We have always believed that mind exerts some sort of influence on the body, and it's vice versa. There's a bidirectional influence which tends to be there, right? And that is something which entails the mind body connection. So with what was previously called psychosomatic medication, today it what we look at are psychosocial considerations that are there, right? So psychosomatic is derived from a Greek word which is split into two halves: psyche, which means soul, and soma, which is body. So psyche, meaning soul, is something that all psychology students would be familiar with by now. It's something which keeps coming up, right? So psyche and soma, so soul and body, right? What it focuses on is understanding the underlying psychophysiologic mechanism. So how, like, things, psychological factors influence the physiological mechanisms, how body gets impacted because of whatever goes on in the mind. So how you think, what you think, the nature of your thoughts, how that influences your feelings, how that influences your behavior, how all of that is interconnected, right? Research confirms the prevalence of various psychiatric problems in inpatient and outpatient medical settings. So, this is not a hidden fact that people who are admitted in the hospitals, a lot of people would have psychiatric comorbidities in addition to what they have been admitted for, the concerns that they have been admitted for, whether it was something to do with heart disease, whether it was something to do with kidney disease, whether it was any sort of admission that was happening. There are psychiatric comorbidities that have been found, and this is something that research confirms, right? These psychiatric comorbidities can be in the form of anxiety, can be in the form of depression, can be in the form of other illnesses, right? Which Dr. Kedar can perhaps help us understand. So, Dr. Kedar, of course, being a psychiatrist, help us understand what are some psychiatric problems which we, I mean, of course, that's like a separate part also, but like maybe something to help us understand this point better.
All right. So, and I'll give you something which is not on the slide, just to give you something to chew on when we do go into that break. Think about the entire body and give me one area, one organ system in your body which is not related to psychiatry. Yeah, today I'm asking questions like the MCMI, so I'm sorry about it. But think about the entire body from your hair, tip of your hair to the tip of your toe, and think about any organ system that you can think about which is not affected by psychological concerns. And it came as a shock to me because, yeah, Deepika, you're right, none. Because when I went into medicine, I thought I was done with reading Davidson's and Hutchison's and all that stuff. But guess what? Even in radiology, there is a condition which has a psychiatric basis. Okay, radiology, which basically is what to do with X-rays and USG scans. There is a condition which has to do with psychology or psychiatry. All right, very interesting the way it presents and what it does. But there is absolutely no system in your body which will not get affected by how you. I'm not saying ki there will not be concerns with plumbing. I'm not saying ki issues with your plumbing in your heart, which will lead to myocardial infarction, is purely psychological. I'm saying ki a lot of your stresses affect the way your physiology works, and this will cause problems. Yeah, Deepika, I'll tell that condition at the end of the 3 hours so that you hang on to this because it was actually a very funny condition. And I actually went and messaged all my UG batchmates saying, no, the entire thing is complete. There is no such thing as not being affected by psychiatry. We'll discuss this towards the end as an exercise. It's funny, all right? But yes, everything that she's saying, and you need to understand, if it is not being precipitated or caused, it can be worsened or the treatment can be affected. And this is why psychosomatic concerns are now being looked at very seriously. There are a couple of things I want to address. Okay, when we are discussing psychosomatic concerns, someone asked whether pain is psychosomatic. The answer to this is simple enough. We will consider psychosomatic issues at the end of it all, because if there is a biological reason for the pain, then we have to treat it. So, yes, there is very much a psychosomatic nature to pain. And as you all were pointing out, the interpretation of pain depends on your experience and how you are going to look at things and anticipation and your personality type, etc., etc. But if there is a biological reason for the pain, you treat the biological thing first. Okay. There was a second question asked, which has got lost somewhere. Uh, what are the current interventions in psychosomatic medicine? And there is a lot of work being done in oncology, even in diabetes care, in a lot of chronic issues. In COVID, we figured out how to use art-based therapy in ICU settings. So a lot of new interventions are helping people along with mindfulness based stress reduction techniques which help. So these are all conversations for later in the topic, but since you had asked, and I thought it was pertinent to answer, right? um, you want to take this? Should I?
Yes. So this is again like this is the point that you just made, that even though, so if we speak about mental disorders, they can be both a risk factor and poor prognostic indicators in chronic medical illnesses like cardiovascular disease, diabetes, and cancer. So you may like it may not be present at the time, but it is something which can exacerbate the condition, or vice versa. It can be a risk factor for a lot of chronic medical illnesses like the ones that are mentioned right across the screen. And co-occurring mental and physical disorders contribute towards public health problems. So it's not something which an individual struggles with, it is something that a community struggles with.
Yeah,
Right.
the burden is tremendous. I mean, I was giving you an example of DOTS treatment for TB. Imagine the problem that occurred because of the fact that people were not taking the medicines. Remember, drug resistant tuberculosis, if you get infected with it, you will have drug resistant tuberculosis. You will not have normal tuberculosis. So it was the intervention with DOTS which helped. Now I'm aware that I'm talking to a very sensitive group, but I have to mention this. HIV was a pandemic proportion. In fact, I remember that it is still a pandemic, by the way, but the way it was flowing around, it would have been a huge crisis. What helped was psychoeducation. What helped was the fact that someone came up and said, we are going to break the stigma and we are going to make plastic or condom available at the cheapest rate possible. And that helped reduce the occurrence, helped pro- protect people over an entire um, over an entire generation, and stopped it from becoming a huge crisis. It is already a problem, but it actually wasn't simple enough intervention. The fact that people had to become aware of it at an early age is what we have learned. So these are all examples which you will start seeing as you go along and realize the psychological or the behavioral part of it, which helps it go from a public health issue to something that is going to happen on a controlled basis. Yeah. So that was it. And since we are talking about the impact of public health, I should probably mention this: vaccine avoidance in COVID. The Beck Institute actually came up with a very nice presentation for vaccine avoidance, how to counter it in people who have vaccine avoidance during COVID, and it was made available to all health practitioners free of cost, and it worked. Now, these are things which we will not even consider on a day to day basis, but it helped, it had a huge impact in controlling the scenario and reducing the stress. Yeah, so the conversation does translate here. Right?
Right. So, thank you,
Hmm.
Dr. Kedar. And we've heard your request for a short break, which, of course, most assuredly, Dr. Kedar and I would very compliantly agree to. So, yes, it's a 5 minute break time. So, quickly, those of you who are able to make it in less than 5 minutes, go for it. And let's take a short break, and we would resume soon after. Hello and welcome back. I hope we've had the break that we needed, a short and crisp break. And don't worry, we would be giving you breaks in between so that you're able to retain this information and you're able to put it to use because that's the whole point of doing these sessions, right? So, while Dr. Tilve joins us back after the break, let's try to join in and maybe take a moment of reflection of whatever you've uh, been able to, you know, take in so far. Think about how it makes sense. Think about how that specifically uh, relates to things that you see around your own self, things that you've observed in your families, around you in the community, and things like that. Make it as applicable as it can be so that there is optimized learning. So think about that. And while we also discuss some facts and figures. So, Dr. Kedar is here. And now we move to our second segment after the break, which would be about examining a few facts and figures. Something which is a wake up call for all of us, something which all of us need to take into account so as to embrace reality, and do away with the myths that we've been living with all this while. Well, because of misinformation, lack of awareness, and the stigma that surrounds us. So, when we talk about facts and figures, let's start by examining that delirium as a clinical condition. It occurs in approximately 20% of inpatients, you know. So, this is something which I feel, of course, Dr. Kedar is going to be a better person to talk about here when it's about clinical conditions in the inpatient setting. So help us understand, these stats and where do they make sense.
Okay. All right, guys. Hope you had your coffee and all of you are back. I actually had to make mine, so I'll drink it along as we go. But the question that Stuti asked, what is delirium? I am. I was given to understand that a very nice gentleman took your case history and MSc. So I'm going to assume that you know what delirium is. It is usually a condition where your orientation to time, place, and person is lost. And when that happens, it means most of the times that it is being precipitated by a medical cause. All right. uh, the easy way to understand is your orientation to time, place, and person is gone. Remember, time, place, and person goes in this manner and returns in this manner. Okay, so that is the hallmark of delirium. But the cause is medical. The presentation, however, is usually psychological. Patient starts muttering, patient starts behaving erratically, aggressive, irritable, violent sometimes. There's picking up behavior, they'll start searching things and talking irrelevantly. It reaches a stage where the people in ICU are no longer aware of what's happening with the patient, and the need to try and intervene becomes high, but the cause is most of the times medical, not psychological, and as a result of which we have to point out to them where the delirium comes from. This is important because if you miss a medical condition, delirium will most likely prove fatal. You have to identify the cause. That said, now this is a confounding aspect of it. There is something known as ICU psychosis. Okay. Now, ICU psychosis happens because you're in an alien environment. They're just continuously having white lights thrown at you. Extremely high stress environment. So your sleep wake cycle has gone for a toss. And 3 or 4 days into the ICU stay, the person starts blabbering, becomes irritable, orientation is lost, and will present exactly like delirium. But the reason for this is the stay in the ICU. Okay. The treatment for ICU psychosis, actually, Stuti would be able to tell you better than me because it is usually putting them in a place where there is exposure to sunlight, and if possible, shifting them out of the ICU. Two very closely knit conditions, but one will prove fatal if the medical intervention doesn't happen, and one will prove problematic and worsen if you keep the person in the ICU. Someone just asked, is it the same as psychosis? It is not. It is known as ICU psychosis because it's a misnomer. It is delirium precipitated by staying in the ICU far too long, not having the proper orientation that you do. For this, you actually have to go and reorient the patient over a period of time regularly. And this is where counseling psychologists help the highest. Who would have thought that a psychologist would have a place in the ICU? But many times, my counseling psychologists at my units actually go there and help orient the patient and help the relative talk with the patient. There's a way to talk with them. You can't simply go there and say, "Ki boss, why are you not doing this? Why are you doing this?" It doesn't work that way. So reorientation is a process that psychologists help with, and will actually be very, very beneficial if you take this on a regular basis. All right. So that is delirium. Now, what she was pointing out to was 20% of inpatients have delirium. Okay. And before I move on, someone asked, what is inpatient? Inpatient is any person who is admitted, okay, in the hospital. An outpatient who comes to the OPD and goes away. All right. So you have to remember that delirium is common and cognitive reorientation helps. There was a very interesting study done, all right, before we get too stuck on one thing. There was a very interesting study done known as CADSIL study, which led eventually, after a lot of years of hard work, to something known as cardiac depression. Heard of this term? It is depression which occurs post any cardiac event. Initially, it was thought to be post an MI or post a heart transplant surgery, but now it is found that anything which involves any cardiac event, you can have a depression which lasts for 6 to 9 months and then reduces and goes away. Depending on the intensity, we decide whether to treat or no. All right. This is what happens post a illness. There is also something known as worsening of your risk factors, in which you will more likely have a cardiac event because you have depression. Now, this is slightly complicated. We'll come to it when we are discussing this. All right. And like we have been harping about this continuously, it has been found that mental illnesses, especially depression, affect the treatment compliance of the person, which means the adherence to the medicines and the overall prognosis. Whether a person recovers or no comes down to whether the mental health is functioning properly or no. It's an important factor. All right. And this is what you need to remember as we head into this. This were, of course, examples. We'll go to specific illnesses now and try and cover how these affect so that you will understand. All right. Which term again? ICU psychosis. Okay, ICU psychosis is the term. All right. All right, Stuti, if there is something you need to answer, what are the qualifications of a health psychologist?
So, if you look at the prerequisites for health psychology to become a health psychologist, of course, with the new education policy, a lot of things have changed, and we'll get to see how that change sort of pans out. But the minimum would be a master's in psychology, right? And that is something which ensures that you have proper, let's say, educational background and theoretical base to be able to practice in like a healthcare facility. And so it would be a master's, because master's is what offers us a specialization. So graduation and bachelor's is what tends to be, like, again, with the new education policy, you have to see like how that pans out, right? So let's all wait and see how that comes along.
Yes, but we are doctors. We are very finicky people about degrees. So
Yeah.
usually it will take your master's in counseling psychology at least to become a health psychologist. Yes.
Yes.
Uh,
Yes. Absolutely.
Haji.
Right. So, as an extension of that,
One second. It's cardiac depression, guys. The term is cardiac depression. Okay. Yeah. Right.
Okay.
Sorry. Yeah.
Right. So, as we were talking about how there are some clinical conditions which are present in the hospital setting and very commonly seen in the inpatient setting, a failure to identify, evaluate, and diagnose a specific psychiatric comorbidity in medical settings can contribute towards longer lengths of stay. So, the point that Dr. Kedar was mentioning a while back. So, longer lengths of stay, right? Financial costs involved, quality of life getting impacted, family getting impacted, a lot of other factors get impacted, right? So it's a public health problem. It's not just at the end of an individual, it is something which is there as a public health problem, right? So this is also where something which had a good prognosis changes, right? So something which could have been caught hold of in the early stages of onset is something which becomes chronic. So something acute, for example, becomes chronic because of a lack of, a failure to identify, evaluate, or diagnose a particular clinical condition. And as we've been speaking about this, how depression, anxiety are very, very common. Right. So sometimes there's just one point that I'm going to make, and I'd like Dr. Kedar to help us understand that further. So when there is anxiety involved around the procedure, right? So if there is any illness, for example, if you may take, let's pick up one illness like cancer, right? A chronic illness. So the anxiety around getting treatment for cancer, right? The lack of awareness, how there is so much that goes down when it's about, understanding that you've been diagnosed with cancer, right? The whole aspect of uncertainty, the whole aspect of what treatment is going to look like, and other clinical things, which of course Dr. Kedar will help us understand. So, all of those things we need to take into account because that is where health psychology has its relevance, right? So, clinical activities here include your ability to make a decision, right? So, evaluating your decision making capacity, that is very important to assess the quality of life that you currently are at and how we can manage the symptoms. So, whatever you come in with, in addition to what you're struggling with in terms of an illness, what are some symptoms that you may have of any mental disorder, right? What is your capacity to take a call, right? So, Dr. Kedar, please help us understand these things from the clinical vantage.
So a couple of things. I mean, you hit the nail on the head when you talked about cancer. Obviously, we have dedicated a portion of the next slides to cancer, so I'll not dive into this too much. But just to give you an example of how this happened, um, see, cancer is a diagnosis where there are so many options, and all of them have limited efficacy in some cases. A lot of it also comes down to whether a patient will willingly put himself through the treatment. Luckily, we have improvements going on, but we are not there yet where everything is reversible. uh, as Sajan Yu, that's his name, who is the psycho-oncologist with Mulund right now, keeps on reminding me, 1 in 2 people will have cancer diagnosis by the end of 50 years or 60 years. I don't remember the number anyways, but he keeps on saying this. And I keep on reminding myself that there will be calls to be taken where the person is not aware of the implications, nor are they aware of the seriousness of what is going to happen if they don't follow up. So when we are talking of whether the confidence is there, the competence is there to take the decisions, remember, an anxiety will actually deter you from taking an action. Anxiety is a life half lived. It's a life which you will live in second gear. And if you do that to treatment, the threshold will not be met for treatment and you will end up paying the price for it. Okay. So this is a huge factor when it comes to a serious illness like cancer. And more often than not, treatments get deferred, opinions get solved multiple times, reducing um, the efficacy of the treatment and the time that it takes to actually start the treatment. A lot of time helplessness, hopelessness comes in, which interferes with how the patient responds. So all of this is there, and this is what we're going to start looking at. All right. So remember that we are going to look at overall illnesses and how it affects. Right. Can we move to the next slide? Okay. So treatment process usually of an illness, if I had to talk to you about it, would involve going to a doctor, getting treated, and moving forward. You know, it's simple. Malaria hota hai, I get malaria, I go to a doctor, I take treatment and go. And yet we lose people to malaria and dengue even now. That happens because people are not aware of the way the symptoms present. We are not aware of the fact that malaria can have four different types of presentation, and by the time we reach the doctor it is too late. Now, I took a non-threatening example because it's precisely that, it's a non-threatening example. You go to a doctor, you do a malaria test, do it at a spike of fever, see the plasmodium vivax, treat it and move forward. Problem nahi aana chahiye. But even the small thing is missed. Okay. There is someone pointing out that wheezing, okay, which is basically related to your respiratory tract, is precipitated by anxiety. Now, for most of us, this may happen, but if it is going to happen in a person with bronchial asthma, it is going to create all sorts of situations which need to be identified and treated properly. Otherwise, precipitation or worsening of a condition will occur and you will not be able to interfere. So, where does health psychology fit into all this? Where does the treatment process come from a psychiatrist or a psychologist? Okay. First of all, is the assessment. Diagnosis is crucial, and I'm going to say a couple of things now which I want you all to pay proper attention to. A illness can cause depression and anxiety. Prevalent depression and anxiety can worsen an illness by precipitating non-adherence, and the two of them can occur independent of each other at any given point of time. The patient has the right to present any which ways to you. In fact, one of the slides which we forgot to touch on, so I'll include it here, is grief. And one of the responses of grief is a stage of depression, bereavement, or grief stages. You need to bring your clinical acumen to help the team understand what is causing the helplessness, hopelessness, so that they can better treat. अब ये theoretical लग रहा है, but this is the most crucial step to helping the patient. And you will understand how this plays out as we give examples also. It's all monochromatic when I discuss this, but trust me, when I give you examples, you will understand why each and every step has to come first from a proper history, a thorough counseling session, a thorough talk with the relatives also, to understand how you can best help. Now, of course, if there is prevalence of depression and anxiety, pharmacological interventions are there, जो help करते हैं. Even psychosis, pharmacological interventions are there which help. But psychotherapeutic interventions have to be target based. Your dictum of let go of the negative thoughts and think happy thoughts will backfire in patients who actually have physical concerns. And I'm telling you this from experience. See, as psychiatrists were posted in medicine for 3 months. On my first day of medicine posting, I was having a conversation with someone who I knew had an anxiety attack. But he also was going through back pain. And normally the conversation goes very easily. You identify the anxiety and the anxiety reduces. Here it actually worsened because he wanted the focus to be back pain, not the anxiety. So if you go and talk psychological jargon to people who are going through a biological process, they may misinterpret it. In fact, to the extent that there is a very beautiful point in the comprehensive textbook of psychiatry when it comes to consultation liaison. It says never ask for depressive features. What are the normal conversations that you would go and have? You would go and ask the patient, हाँ उदासी लगती है क्या, बुरा लगता है क्या, खुश होते हो क्या, okay? उदासी पूरा दिन रहती है क्या? Are you sad throughout the day? Is there decreased interest in previously pleasurable activities throughout the day? But this is not what the person responds to. What the person responds to is, are you feeling helpless? How do you see the prognosis? And in that answer, in that conversation, you will get the linking to depression or anxiety. Because if the person says, I'm not sure, I'm not very clear, I'm fearful, then it's anxiety. If the person says, no, I don't see a point to the treatment, what's the point of getting treated? I know the prognosis, I know what type of cancer I have, there's no hope, you might be looking at depression. All right. So psychotherapeutic interventions also have to be specific to the people whom you're talking with. Psycho-oncology, which is the branch which is kind of diversifying from normal psychology variants very quickly, they actually have a very nice way of conversing with the patients, because oncology patients will have a complete understanding of what they are going through. So if you ever listen to a psycho-oncologist having a conversation with a patient, it will be very different from what a counseling psychologist will have. But it is required. You have to tailor make the psychotherapeutic interventions to things which will help. Behavioral interventions, like we are going to discuss, have to be tailor made to the illness that you're going through. And all of this has to be put in perspective of, mind you, the actual treating physician. Otherwise, we get so caught up in treating the patient that we forget that the person taking a decision on the treatment himself is a doctor, जिसका jargon पूरा अलग है. So you are going to be holding hands on both sides, one for the patient, one for the doctor, and your job is to basically be a liaison. Hence the term consultation liaison psychiatry or consultation liaison psychology, whichever you want to look at, which is crucial to ensuring that the prognosis gets better. All right. Next slide, please, Sudhi.
So I'd just like to add one point, Dr. Kedar, when it's about psychotherapeutic interventions and behavioral interventions. So as you very beautifully pointed out that, it doesn't have to be about direct questions, ki, "Acha, ye ho raha hai, ye ho raha hai." So we're not robots, right? We don't have to act like robots. We're humans. It has to be therapeutic. It starts there, it ends there. So there is a therapeutic vantage to why you're there in an inpatient setting. So, as psychologists, we just don't work in the OPD, we work in the IPD with the inpatients, right? Imagine being at the hospital, imagine being admitted for an illness. It's never going to be a pleasant experience, right? There is uncertainty, there is sadness, there is hopelessness, there is helplessness. There are a lot of things, a lot of emotions, and assortment of them which any individual can go through. So it does not have to be about like a pen and paper and checking the boxes. That is not what psychotherapeutic interventions look like. They have to be therapeutic. I mean, AI can very well, do that. You can do the basic screening for all of us, and with the interface of AI and mental health, of course, it's quite promising, right? And you've had a session on that, so you know what I'm talking about. But here we're talking about how you need to instill in a sense of hope, how you also, when we were talking about psycho-oncology, you first gauge how much does the patient know, right? You understand what is their awareness of their illness, you understand what do they understand, and accordingly you shape the narrative therapeutically, right? So moving on, factors that play a role in treatment, Dr. Kedar, help us understand what are some factors, psychological factors, and of course, when it comes to uh, you know host of these factors, how do they play a role in treatment?
Right. So let's start with the first one, the most important one, onset of disease. Yeah, the easiest one. How long has it been since the onset of disease? Is there an intervention possible or not? And what's the intervention going to be like? Um, I have been on the receiving end of both. I have been on the receiving end of a situation where intervention was not possible to where an intervention is possible, and it colors how you look at it. The first question that the person will ask you if you tell them the diagnosis is CA is which stage. Mind you, stages are very different, they have very different connotations, and not all stage 4s are irreversible, and not all stage 2s are good. But since we know of all of this, the first question that the patient asks is what stage, and the helplessness, hopelessness starts with that. Because the staging of cancer depends on which lymph nodes are involved and how it's spread. It has got a very technical connotation, but people don't understand this. So onset of disease makes a difference. What level of intervention do you have? Okay, that can help. Second, etiology. Now, for etiology, I'll give you an example. TB, COX, is an infection. All right. HIV, any sexually transmitted infection, the etiology is conscious choice. But for COX, it will be an infection which a person gets because of no fault of theirs. And the helplessness and hopelessness that it causes is very different to what a person suffering from HIV or HBsAg would experience. You see this in relatives also. Forget these ones. If you look at cardiac conditions, the question is always, अच्छा आपको लिपिड्स ज़्यादा आया है तो वो इसलिए हो रहा है क्योंकि आप चीज़ ज़्यादा खाते थे या आइसक्रीम ज़्यादा खाते थे, मैंने बताया था मत खाओ. That's their way of rationalizing. But you talk to them about infections, you talk to them where etiology is going to be something out of their locus of control, and there is a lot of why me and helplessness, hopelessness, which impairs the response to treatment, right? The course that the patient is likely to undergo makes a difference. The treatment they are going to undergo makes a difference. The overall prognosis makes a huge difference. And remember that when we talk to a patient, the patient will have their own understanding of what's happening. I mean, forget physical illnesses, it happens in mental illnesses also. You say कि anxiety hai and they are all like, and you say कि acha this seems to be borderline, and they'll be, oh my god, what is happening? And if you say कि all right, there's a narcissistic trait, they'll be like, oh my god, narcissism. But these are three very different things. So you have to understand prognosis also has to be explained. And what matters is what the patient perceives of these factors. Right? Cognition, personality, Smriti, do you want to talk us through it?
So, when we started talking about health psychology, we understood how it's all of these interrelated factors. When we talk about personality, it's about how individuals respond to stressors, how individuals respond to illness, whatever they're going through. So everyone has their own unique set of traits, right? Some people tend to be, let's say, more receptive. Some people have a higher degree of openness, for example, openness to new perspectives, openness to maybe something, that comes across as a feedback or anything, while other people may be a little low on that spectrum, right? So the individual differences that are there underlying different traits, different qualities, different attributes that we have, a culmination of all of that is what our personality is, right? So relatively enduring characteristics, your personality is something which is relatively enduring, right? So there are going to be some core elements that define you as an individual, the self, right? But of course, now those are things that you can also work around. So it's not to say that I don't have openness, I will not have openness. No, doesn't work like that. It is something that one can acquire, right? By being understanding where you stand, building self-awareness, identifying who you are, what your self is like, working around that. What is it that you would like to build on? So that is why we call it relatively enduring in nature. Cognition is a set of cognition, to put it simply, learning, problem solving, thinking, all of those things put together. So your thought frame around, you know let's say this stressor, the illness, for that matter, in this context. So, what are your thoughts around that? What are the thought patterns? Like when you receive the knowledge of, or when you receive a diagnosis, when there is a clinical condition which has been diagnosed, what are the already existing thoughts? how has this shaped your thoughts? How are these thoughts impacting your approach? Are you trying to approach treatment or avoid treatment? Are you trying to adhere to treatment, or are you demonstrating non-adherence behaviors? Right? Existing coping skills. So coping is something that we'll be taking up as a part of this presentation towards the last segment. So how is it that you bounce back? What is it that helps you deal with situations, deal with distress that illness can bring with it? And the level of social support. So again, as we've spoken about this even previously, so social support acts as a protective factor. When we speak about social support, let's understand it's at the level of a community. It's at, it goes beyond the self. So when there are biopsychosocial factors, we cannot give one more importance than the others. They all go hand in hand. So social support is also how much social support you have, what kind of resources that are there in terms of social support. Who are the people that you can turn to, right? Is there openness around, unmuting yourself, talking about these conditions, talking about how you feel, what you feel, right? How will that be taken? So all of those things are relevant from the psychological and psychosocial paradigm. And these are some factors that play a role in treatment. So some common psychosomatic illnesses. Dr. Kedar, please run us through these
Yes, yes,
illnesses.
yes, yes, yes. Um, Chehel just asked, ma'am, will you talk about disorders? Chehel, good news and bad news. Good news, we are going to talk about only disorders for the next 1 hour. Bad news, it's not going to be ma'am doing much of the talking, it's going to be me. So take it how you will. But we will be discussing disorders, all right? And we'll be discussing psychosomatic illnesses. To give you an understanding, psychosomatic illnesses are illnesses which will worsen, deteriorate, or complicate based on psychological stresses, right? And there were a list of 7 drawn up initially, जिसमें से wait, Chen, I'm joking, all right? I'm always joking when I'm on public platforms. I never joke when I'm in private, all right? So please don't take it too hard. By the way, common psychosomatic illnesses are illnesses which will worsen because of psychological interferences, all right? List of 7 was drawn up initially, जिसमें से I have somehow managed to miss the most obvious one, and I'll talk about it as an example later. Those are rheumatoid arthritis. Okay, but if you look at conditions which will worsen because of stresses, like we discussed, everything from the tip of your hair to the tip of your toe, but more importantly, these ones here, all right? Peptic ulcer, hypertension, coronary artery disease, diabetes, headache and chronic pain disorders, skin disorders, obesity, and other eating disorders. Obvious situations which will worsen if you're not careful about how you manage your psychological stresses. So, before we move to the next slide, a word on peptic ulcer. Well, peptic ulcer is a very interesting phenomenon in medicine purely because it was the one thing for which we found a cause. Okay, helicobacter pylori करके होता है, but even then the researchers found कि it only caused that situation in some of the patients. In other patients it did not. So it was the stress which was worsening the situation, which contributed to whether or not a person would have a perforation or a complication of an peptic ulcer. Okay, hypertension and coronary artery disease, diabetes will be discussing as we go along. But quite seriously, tell me, how many of you, after being seriously anxious or stressed, will have a precipitation of migraine? All right. After my school open days, 2 people used to have headache. One was my principal, who used to not understand what he was going to do with me, and the other was me, who used to not understand what was going to happen to me. But I used to have an headache immediately after the open day, and it was almost always psychological. Okay, and it led to a lot of pain. Okay, and a lot of anxiety, but it did happen. So migraine has a psychological basis to the extent that the treatment is actually a type of antidepressant and a mood stabilizer which has a specific biological concern. Nisha, we're going to come to digestive issues. There is a full slide dedicated to it. One of my best friends is a gastroenterologist. I keep on telling him he writes more antidepressants than me. So we'll come there. The same thing I can say about skin disorders also. I challenge you to do this. Go back to any old term skin specialist and look for how many of those prescriptions actually have an antidepressant. Right? This was a joke cracked by medical representatives for time immemorial, saying that more antidepressants are written by gastroenterologists and dermatologists than by psychiatrists, which is true. And it helps because stress can worsen some dermatological conditions, can lead to a lot of body image issues also, and leads to mood swings, which leads to bipolarity being one of the precipitating factors when serious derma conditions are there. Okay. Obesity and other eating disorders. This was a statement made by a general practitioner. He said, and I loved him for it, he said 80% of your obesity is in your head. And I've always used this as a guide to remind me that there will be situations where there are metabolic conditions, where there are psychological conditions, there are physiological conditions. But to work on that particular person, to get them that motivational level, to reduce that obesity, to get it down to manageable levels, you have to convince them to do this on a regular basis, which means you have to build up the motivation so that they get rid of whatever hurdles they are encountering when they deal with obesity. All right. Other eating disorders, well, if I start talking about them, we might actually run out of time. So we'll discuss bulimia and anorexia when we come to it later. All right. I'll take a couple of concerns here. One is, can stress or anxiety lead to body pain? Is it a psychosomatic condition? Again, Vedika, if there is an actual medical reason, it is biological pain. Psychosomatic is only a situation where it's going to worsen. There are certain conditions in which a somatic symptom may be the point of concern for a person. So that's known as somatic symptom disorder, something we'll discuss later. Yeah. Um, Digestive issues, yes, we're coming to it. A role of psychological factors in illnesses. So there we are. Illnesses start. Now, if I ever forget a illness, you can ask me at the end. I'll tell you how it affects and what are the psychological concerns we get at it. But we are going to have some case discussions here. All right. Just to give you an understanding. Deepika, is cancer also psychosomatic? No, it is not, because if there is a biological reason for it, it is not psychosomatic. Okay, it is not psychological. You can't think about cancer and get cancer. You can't worsen cancer. You can worsen the prognosis by not taking the treatment. Slight difference, okay, but huge difference. So again, psychosomatic for conditions which will worsen, not conditions where adherence is going to get affected. Okay. So, case discussion, the long way home. I have learned to ask this question after looking at this example. So, I'll give you the scenario. 40-year-old guy, type A personality, or when I say type A, go-getter, absolutely fantastic guy, came to me smiling. He is a success at everything he does. All right. But he came to me after scheduling 3 follow-ups, and I was wondering, why has he not turned up? Who is this guy who is coming regularly but he's not turned up? When he came and sat down, I found out that every time he scheduled a follow-up, he would not come because it was a psychiatrist. And every time he did not come to me, the cardiologist used to shout at him, saying ki ja baat karke aa, I am telling you there is a concern. This guy had actually had a cardiac event. He had had a heart attack. He was a 40-year-old. Okay. And this was pre-COVID. So for a 40-year-old to have a pre-COVID heart attack was fairly uncommon. So there was a reason for his anxiety. There was a reason for his worry. But the cardiac issue had been treated successfully. His cardiologist had told him, ki, boss, you don't need to worry. You're fine. You will do fine. We have treated it. Nothing to worry about. Go about your routine. Stop the smoking. Stop the drinking. He stopped the drinking, right? Not the smoking. And then this 40-year-old comes up of all the time in July or August 2020. The reason he had been referred was every time he went to a cardiologist, he went with 3 or 4 ECGs taken at different hospitals. भाई साहब को to get from his home to his office used to take 1 hour. Okay, that is the travel time. In Bombay, it is 1 hour, and for all those Delhi people, we count in hours. In Bombay, we don't count in kilometers. We count in hours. Huh? But this guy was so scared that he had mapped a route which would ensure that there was an access to an hospital at every 2 to 5 minutes. क्यों? क्योंकि अगर उसको हार्ट अटैक आए तो इमरजेंसी वार्ड में जा पाए. एंड बॉम्बे टाइम्स के हिसाब से 1 घंटे का ट्रैवल बिकेम 3 to 4 hours. It was at a level that he said, and this was his words, I don't want to go to any hospital. So the 5 minutes hospital also have to be reputable hospital with the facilities required to treat my cardiac event. कोविड चालू हो गया 2020 में. वी आर स्कैर्ड ऑफ स्टेपिंग आउट एंड दिस गाय स्टिल मैनेज टू विजिट इमरजेंसी रूम्स every 5 to 6 times in a month. That is why he was scheduling those follow-ups with me, because his cardiologist was shouting at him कि जाके बात कर लो. This is the situation of a person who is fully functioning, successful, married well, uh, happy marital life, happy family, but everyone knows कि it will take him 6 hours to come back in total travel time. The diagnosis, interestingly enough, was panic disorder with agoraphobia. It was not illness anxiety. Because when we started talking, we realized he was scared of traveling bridges, he was scared of open spaces, closed spaces, everything, fear of help not being available. The long way home. The questions that I have learned to ask cardiac patients, I have learned to ask anxiety patients. कि how much time do you take to get home? And usually it is their spouse who will tell me कि sir normally 1 घंटा लगता है पर हम थोड़ा सा डिटूर लेते हैं 1.5 घंटा लगाने के लिए. Okay. This is important because this, when I talked with the cardiologist saying this is panic disorder with agoraphobia, he was like, oh my god, thank you so much for that. I did not know what words to use. And the patient was like, oh my god, thank you so much for that, because my doctor kept telling me there's nothing wrong with you. And he couldn't believe it because the phobia symptoms were there. This is the extent of what happens when you don't know the nomenclature to use or the nomenclature to Google. This guy is successful, remember, Googled everything, but he had not Googled what mental health would do to him if he had an ongoing anxiety about health concerns. So this was the long way home. And this brings us to cardiac conditions and what can happen. All right, here's the catch. Depression is associated with double the risk of development of coronary artery disease. What is coronary artery disease? Something which leads to the blockage of your coronaries. Okay. Chronic mental stress contributes to the development and progression of coronary artery disease. Now, there are physiological mechanisms why this would happen, but remember that lifestyle factors also get affected. We were discussing alcohol, we were discussing other conditions. A lot of people will actually end up binging on alcohol, taking nicotine. Do you know why? To reduce the anxiety and stress that comes from depression. It's a sort of self medication, a physiological solvent for your anxiety, which tends to affect you. This complicates the coronary artery disease. This quickens the coronary artery disease, and you have to intervene properly. All right. Reversing any one of these things, stopping this alcohol, stopping the smoking, would go a long way in ensuring that there is no interference. But the significance is lost on patients. So remember this when it comes to coronary artery disease. Remember I was talking of cancer studies, again, something similar. Next slide, please. All right. Now the commonest one, hypertension. Okay, blood pressure, commonly associated with anxiety. मतलब all of us have seen हिंदी movies जिसमें बीपी मेजर करते हैं और बोलते हैं कि स्ट्रेस लिया है, अभी ज्यादा स्ट्रेस मत लो नहीं तो हार्ट अटैक कभी भी आ सकता है. All through the measurement of an BP cuff. So it is associated with anxiety. Depressive features sometimes may be associated with medicines. All right. And because of the psychological connotation that blood pressure and diabetes have in the normal population, remember, it tends to have a huge blow to the patient. So many people will come and tell you very proudly, हमको diabetes और blood pressure नहीं है. Okay, but तुमको alcohol abuse है, तुमको nicotine abuse है, it's a matter of time, you have obesity. पर हमको ये दो चीज नहीं है. They are proud of it. See, in our psyche, in the Indian psyche, it is set you are healthy if you don't have hypertension and diabetes. Yes, how many of us have encountered it? And it is very, very true when it comes to the cultural connotations. But it is also true कि अगर तुमने diagnosis दे दिया तो the first counter that comes is okay, now don't tell me how to treat hypertension. The first counter that comes is पर मैं तो पूरा healthy हूँ, मेरे साथ कैसे हो सकता है? See, the helplessness starts there. Okay. Sometimes it comes down to a situation where symptomatic control is required, where anxiety needs to be managed. All right. So we'll talk about one particular condition which is funny for all the wrong reasons. Okay. This comes from the cardiologist. Okay. They say कि boss, we don't know what to do. हमने blood pressure नापा. Blood pressure is 190. Patient को BP medicines दिया. Patient को चक्कर आ गया. What do you think happens? One of the places where hypertension becomes psychosomatic. White coat hypertension. I love this thing purely for the nomenclature and the understanding that it will give you about what happens. See, white coats are white coats worn by doctors, nurses. Initially, everyone had to compulsorily wear a white coat, something that I still insist on my counseling psychologists doing when they go to hospital ward, purely because it gives them the authority and it gives them the suggestibility that comes along with it. But along with this comes the fact that I'm going to get evaluated, and so the anxiety worsens. So whenever a BP cuff is attached, the blood pressure shoots by 20 or 30 systolic. So it comes from 130, 140 to 170, 180. And it leads to a situation where erroneous diagnosis of blood pressure is established. तो उनको दवाई मिलती है ब्लड प्रेशर की, होती है एंजाइटी, जो डॉक्टर्स के सामने से चले जाओ तो कम हो जाती. So now they are taking BP medicines for a blood pressure of essentially 120 by 80 and they get giddiness. It takes a cardiologist 2 or 3 follow-ups to look at this and understand this because there are other parameters, but they catch this and they tell the patient you have an anxiety variant known as white coat hypertension. Please follow up with the psychiatrist. And their first response is, हम पागल नहीं है. And it becomes difficult to explain to them that the white coat hypertension is happening because of the fact that your anxiety is precipitating whenever you see a doctor. They usually have a latent anxiety concern, so we need to treat it. Okay. But the understanding, the conversation that has to go into it is equally important. And this is where counseling psychologists also play a role. A simple procedure in which they themselves will apply the BP cuff may sometimes work, sometimes may not work, because they tend to get anxious because of association. Now they are no longer scared of the white coats, they are just scared of the BP machine. So BP machine lagaya, to blood pressure बढ़ जाता है. So this is white coat hypertension, a very interesting fact that we have to touch upon when we talk about health psychology. Next slide, please. Okay. Yes, people were asking so many times about gastrointestinal disorders. Okay. And I'll talk about it in 2 things. One, the gut-brain axis. Okay. When we talk about the gut brain axis, understand that innovations are also found in the gut. So something which will affect your brain will affect your gut too. All right. And a very important condition known as irritable bowel syndrome. This is the commonest reason why gastroenterologists are writing antidepressants. And the treatment is actually amitriptyline and chlordiazepoxide. Other gastro conditions can actually flare up. So you have inflammatory bowel diseases which will flare up when you are under stress, which needs to be intervened with, which needs to be treated with. And this is extremely important when you talk about GI concerns, because remember, if you fail to identify this, the patient will not be treated fully, will run from pillar to post. Okay, next slide, please. Oh, by the way, CBT, just go back, please. One minute. This last point is important. CBT and supportive therapy was found to be helpful. So, what it basically tells you is if you can talk with the person in their jargon, you would help reduce the either the intensity of the symptoms or the intensity of the depressive illness to manageable levels. All right. So that's GI disturbances. If you want any other further clarification, you can ask again. We'll cover the next slide, Stuti. Then we give them a 3 to 4 minute break, perhaps. So this is purely because we have already discussed cancer in some detail. So I'll give you an overview. Psycho-oncology is a very, very important sub-branch of psychology right now. It is developing, and we need to put more effort into it for some simple reasons. Okay, and they are there right in front of you. The moment the word comes in front of you, cancer, okay, there is a fear of death. There is also a belief in the certainty of death, which is not true. There is the extreme dependency. There is a disability which is produced because of the treatment, because of the illness. It's also feared that there will be a poor death, which actually interferes with a person's thinking. There are serious financial conditions which are imposed by the treatment. There is a disruption, a transition in the role that a person plays. They may go from a fully functioning member to a person who is completely dependent. And all of this causes a huge turmoil in onco patients. Okay. And it can happen at any point of time. And when I say any point of time, I just don't mean people in the onco ward. I am talking about people who will undergo a biopsy for the suspicion of a malignant or a cancerous lesion. So, most of you are aware that benign conditions होते हैं, malignant conditions होते हैं. Benign conditions fairly obvious होते हैं. When we take a look at it, we know it's benign. So there was a patient of mine who had a lump in a breast. This was a benign lipoma. This is the simplest breast mass that happens, very common, not to be confused. But because of precaution, the surgeon said कि हम biopsy लेंगे and will rule out that it's not cancerous. And do you know what happened? Her mother, who is an anxiety disorder, precipitated a whole new attack of generalized anxiety disorder because it would take 15 days for the confirmatory report to come back. 15 days later, the confirmatory report came back saying it's a benign condition, it's in breast mass, it's a lipoma, don't worry about it. Okay. But the generalized anxiety had already started in my patient, and she took the treatment for that anxiety disorder for the next 6 to 9 months. I'm talking of the caregiver in a patient who did not even have cancer. In patients who have cancer, this can occur at any point of time because of the drugs, because of the interventions, because of the anxiety, because of the financial stressors, because of the social implications, because of the physical side effects, hair loss that is produced. All right. So it's a very, very difficult situation which requires a helping hand and an understanding of the jargon that is going to be used. And that is wherein psycho-oncologist plays a role. Okay, so some of the examples are there. Psychiatric disorders in nearly 50% of the patients, I would say we should actually take a look at the caregiver burden also, because there is a high degree of depression and anxiety seen in caregivers too. All right, gauging and patients' understanding of the illness is extremely important. I have seen people give away money, sign away accounts because they felt that this was not going to have a prognosis. All right. Um, Psychotherapy helps, and I let Stuti talk on it. Okay, I'll let her discuss some of the points because this is important. Okay, but this is something that we need to be aware of, and this is one of those places where someone who is a psychologist who has spent their time, roughly 2 to 3 years in an oncology ward, gets familiar with the jargon and helps them with a guiding hand through the next process, which is extremely important, improves the prognosis hugely. Right, so do you want to take over?
So I'd pick up the point where we need to understand that cancer as an illness, uh, of course, is debilitating in the sense that from the point where it is suspected to you receiving a confirmed diagnosis and then seeking treatment, and the treatment outcomes, battling the treatment effects, all of those things have to be taken into account, right? One very telling thing that we really have to focus on is that more than two-thirds of people who've been diagnosed with cancer also have an adjustment, tend to have an adjustment disorder, right? So it tells us very convincingly how other factors around, illness precipitate the illness, and at the same time it make these factors make it worse, right? So when we are talking about patients understanding, that is one thing that one must not compromise on. As psychologists, it's paramount for us to take into account how much does the patient know, what is their understanding of their illness, how is it that you can tell them, educate them about their illness, the prognosis, the course that it's going to follow, and the treatment? How is it that you can psycho-educate them around the treatment effects? What is it that you need to take into account when it comes to various factors like their cognition? How do you assess? So when you're speaking to patients who are battling chronic illness, so you just don't go in with a pen and paper, as I mentioned before. You need to understand each and everything about the patient, right? Their background, where they come from, what is their level of understanding, what are some of their personality traits that you as a clinician you have been able to assess. How is it that you can make use of all of that knowledge to help the patient? How is it that you can sort of support the patient through supportive psychotherapy, right? Psychotherapy with individuals and with groups lowers distress. So what is fairly obvious at this point is that whenever there is distress associated with illness, psychotherapy looks at lowering that distress, managing the symptoms of anxiety, symptoms of depression, any sort of distress which may be seen in patients struggling with cancer. Here we're talking about cancer, so specifically, we'll talk in this context, right? It also increases an individual's self esteem. So here we're looking at empowering patients by looking at themselves not in context of their illness alone. So you are not equal to your illness, is the idea that we empower patients with. So self esteem is your perceived value or worth. So how is it that you need to reclaim other aspects of your life? And go back to the slide that we spoke about, where we're talking about, uncertainty, fear of death, roles, functioning, right? The ecosystem that gets impacted. So as psychologists, we don't just work at the level of the individuals or the patients, but also with their caregivers, right? In helping them understand, in psychoeducating them that a lot of time this irritability that they may have is not within their control. It could be because of the treatment effects. It could be, so a person is not choosing to be irritable, right? Simply, let's put it like that. It's happening for a reason. It's happening for a very well defined reason, and that illness explains a lot of it, right? It also enables people have a sense of control. So where is your agency here? Your agency comes from seeking treatment. Your agency comes from approaching healthy behaviors. Your agency is about making the right choices. treatment adherence, right? So all of those things put together come under the purview of psychotherapy and counseling. So how is it that we can empower them with thoughts? So it's not that, you know, you give them a sense of false hope. No, that's not the idea. That's not the idea. The idea is to understand where and what the illness is about. Where does it stand? How is it that you can lower the distress in that moment? How can you help them relax? How is it that you can build in a sense of acceptance? And acceptance comes in much later. There is also a sense of disbelief, which precedes a lot of things, right? So, how can you move successfully through those stages is what we understand. We build a sense of confidence. We work towards decreasing anxiety, and all of those things put together come under the purview of psycho oncology. So, again, cancer, of course, associated with all possible spectrums of mental health concerns, depression and anxiety being the most common ones. And it is something that is associated with highest caregiver burden, something that Dr. Kedar, of course, he'll be able to tell us about where, you know, these things come into the picture.
Yeah. So, caregiver burden will make an impact on how the person perceives their overall situation and will actually impact their treatment outcomes also. Remember that caregivers have to be there for the patient through the entire process, through uh, sittings and the treatment and the prognosis and the waiting with bated breath for finding out what has happened. And this is all very technical, which both the caregiver and the patient does not understand. So it leads to a lot of distress, it leads to anxiety, depression, and the quality of life gets affected drastically in the person who is the caregiver. And as a result, it affects the interpersonal relationship of the patient and may affect how they perceive their improvement. So this is extremely important when it comes to all chronic illnesses, not only cancer. Adherence to treatment gets affected because people become helpless, hopeless very quickly if they see their surroundings get dejected, if they see people surrounding them getting dejected, if they give up hope. So targeting the entire family becomes absolutely crucial, something that psycho-oncologists are extremely good at. Now, can we move to the next slide? Yeah. So diabetes. Yeah. Quickly, just to understand this, because we're running short of time, associated with depression, anxiety. In fact, does depression cause depression and anxiety? Does diabetes cause depression and anxiety? And does anxiety and depression worsen the diabetes? The answer to both is yes. Okay. Extreme mood swings are associated with diabetes, basically because of fluctuation of sugar levels. That age old adage that was there, in which your mother told you either to go to sleep or eat something, is actually true. If you are hungry or hangry, you will actually tend to become more irritable. In patients with diabetes, it increases the level of irritation so that they can become irritable, almost aggressive, if sugar levels dip. If sugar levels worsen, it is associated with confusion. So many times there are situations where we don't know what's happened. I remember a patient who had presented to casualty. He was saying कि मैं खुदा हूँ, and everyone wanted to go and inject him. And we're about to inject him with lorazepam, which would have knocked him out for 2 hours. And the IV was almost about to go in when one of his relatives who was standing back said कि सर इनको डायबिटीज है और 2 दिन से दवाई नहीं ली. So we thought that he might have high sugars. So before injecting, my CR said कि boss sugar level check kar de. Now remember, this is casualty. 10 people are holding him down. Okay. And we actually went and checked the sugar level, and it came 26. We thought that the sugar levels were wrong, so we checked it on the other hand, and it came 24. वो IV हमने ऐसे ही हटाया, लोपेस दिया नहीं. We gave him a proper glucose का infusion, and he improved immediately. The person who was shouting कि मैं खुदा हूँ from the past 2 days sat up within half an hour and said कि why am I here, and why are you looking at me like I'm foolish? And he had a complete conversation. Turns out he had a very, very unique condition in which the sugar levels dipped in the mornings. And because he was erratic with the medicines, it caused the sugar levels to dip to 26. Remember, 70 and below, you'll start getting all sorts of complications. यहाँ पे 26 था. If you had given him lorazepam, it would have been the end of the patient. So this is the level that it can get affected. Interestingly, happily, and this is where people are asking me, where does the digital interface come from and help? Well, in diabetes, it will always help. Okay, and this is why HbA1c levels, which are 3 month use of sugars, how you have been using your sugars, they'll measure, actually have been found to improve with treatment with antidepressants. Acetalopram या fluoxetine लिया तो there is 1 basis point improvement or 1 HbA1c level का improvement seen in patients. All right. Consequences of some psychotropic medicines can be diabetes. Okay, it can be a side effect, and it was improves also with an antidepressant treatment. So this is where we are at. But to answer one of the questions that you guys asked, can diabetes have a psychosocial intervention? The answer is yes. And I have been happy to know that a lot of endocrinologists, forget psychiatrists, forget other people, endocrinologists are actually involving therapy sessions where they talk to the patient about mindfulness interventions, where they talk to the patient about counseling. These are online interventions, actually, incidentally, which is helping improve the quality of life. Okay, which helps improve the way the person perceives how they're going to binge eat. Mindful eating practices to a person who tends to binge eat will reduce that binge eating, so it helps. All right. Now, Stuti has very nicely turned the slide because we are running late. So I'm going to ask you a question. Is it okay if we take the break in 5 minutes for 2 minutes? If so, we'll cover this topic now or we can take a break now. All right. Oh, by the way, someone's asked diabetic neuropathy can cause depression. Yes, it can, because most of the time people don't find an answer. They feel that the pain is unwarranted. Depression, anxiety, and irritability happens. Yes, so I've seen it. And I'll tell you an example. Quickly, pulmonary disease and COX is something that we'll be discussing when we take in 2 minutes break. 2 minutes break, Stuti. I'll answer other questions till then. So it is 17:16. So we'll come back at 17:20. 2-3 minute का break. All right. Thank you. All right, hey guys. So we are back on the dot purely because we are late. So um, we'll start now. Okay, pulmonary disease, disease of the lungs, right? How important is it? Well, I'm going to give you one thing, that is TB, and I'm going to tell you why also. Uh, when I was in senior registrar, I got an offer to work in something known as Sivri TB hospital, which is drug resistant tuberculosis all over Mumbai. Used to come to one hospital where we treated the case. When we went there, they actually gave us a requirement for 7 psychiatrists to work in a tuberculosis hospital as psychiatrists. Okay, and this was a alien concept at that time. No one did this. No one asked psychiatrists to come in a work in a super specialty hospital like that. But it did that, and we went there. And when we went there, all our colleagues were smiling, saying, "Why are you going there? It's Cox. You will get infected. Why are you going there? You don't have to go there. No need. What are you possibly going to go and do there?" When we reached there, we were given a very scary stat. We were given a stat which said ki that hospital saw one self harm, completed self harm, that is one completed suicide per week. Many times it saw two. This is because drug resistant tuberculosis is a extremely difficult to treat condition which can affect other people around you and carries a very bad prognosis. It reached a stage where they were so unsure of what to do that they covered the entire hospital with grills. And when they covered it with grills, it reduced the frequency to once in a month, but we are still losing patients. So the rule was psychiatrists would go there, talk with people, and start treating. We were not sure what to do. We were not sure what was happening. And believe me, when we started the treatment, we were not sure ourselves. Ki, why are we here? But within joining, that is 1.5 years I was there, in 1.5 years of active psychiatric screening of every drug resistant tuberculosis patient who came to that hospital, and it's a 1,000 bedded hospital, that's how big it is. Okay. There was one fatality in 1.5 years. We went from one per week to one in 1.5 years, and we spotted why it had happened, and we put in measures to ensure that it did not happen again. This is the level of intervention which consultation liaison can get you. There is a drug, a steroid, which causes all sorts of behavioral disturbances. The team there, the pulmonary team there, actually understood this well enough so that they would send the patient before to us psychiatrists to tell us whether there was a possibility that the patient would get drug induced psychosis or no, so that they could decide which treatment to start. It was a beautiful example of just how well consultation liaison can work and what are the possible levels at which interventions can occur. All right. So there are a lot of experiences that I would have loved to share with you had we had the time. So when we do, I will share it with you guys. But right now is not the situation. So stress and illness, how does it contribute? Okay, I'll allow Stuti to take this.
Right. So this is our last segment for today, where we talk about stress and illness, and of course, this has various parts to it. Right. As an extension, how to manage, what are some factors that we need to take into account. So first, let's start by understanding what is stress. Right. So stress is any physiological or psychological response to internal or external demands. Now, as we started the session, we spoke about how you and I equally are going to face numerous things or numerous challenges in our lives, right? Big or small. Sometimes it's going to be less intense, sometimes it's going to be quite intense, right? These situational demands are always going to be there. So these demands can be internal, these demands can be external. So an example of an internal demand would be perhaps you have an exam coming up, but there is self-inflicted pressure of performing, let's say, really well in terms of how you only quantify 100 on 100 as something which is, is something which you need to strive for. So that's where there is intrinsic self-inflicted pressure, right? Internal. External would be how there are situations, so external demands would include calamities, would include perhaps changes in the environment. In the modern day, of course, with the kind of consumerism that we have, how, you know, all of us have become slightly more egocentric with every passing day, and we tend to only consume and consume, and how that is jeopardizing the environment around us, how that in itself is an external demand, right? So traffic, daily hassles, work related stressors, exams, deadlines, all of those things. Now, why are we talking about this? Because these things impact how we think, how we feel, and how we behave. To put it simply, it impacts us at three levels that we've spoken about. And all of these things are going to keep happening with us day in and day out, right? So, what is a stressor? Let's try to understand that anything that causes stress is a stressor. Any force or event which leads to stress or contributes to stress, which brings up a physiological or psychological response, is a stress. How do we appraise stress? Stress ka appraisal happens at two levels: primary appraisal and secondary appraisal. Primary appraisal, basically, it involves making, or let's say, an evaluation around what harm has already been done by a situation. So, for example, if there is a stressful situation, let's say loss of a loved one, right? So, what is, or loss of a loved one due to cancer, right? Because we've been talking about chronic illness, we've been speaking about illnesses in this context. So, what is the harm? The harm is something which has already been done. Threat is the future. It is embedded in the future. What is it that can happen in the future? So it evokes a sense of fear, it evokes a sense of helplessness, it evokes a sense of anxiety around, okay, like I lost a loved one to cancer. Now, because of the genetic predisposition and other lifestyle related factors, what is the possible threat, right? Challenge is something which is on, let's say, some positive lines, as to it gives me a sense of confidence that I'll be able to deal with it, right? So challenge and threat are not the same. In the present day, a mobile notification is enough to threaten us, right? We're living as a part of these times where even a single notification, a text message, is perceived as a threat. It is something which brings out a physiological response, changes in your body and in your brain, right? So we need to be able to understand what the harm, threat, and challenge looks like. So, harm, something which has already happened; threat, something which can happen in the future; and challenge, my understanding, a positive appraisal that I will be able to manage that. That is primary appraisal for you. Secondary appraisal, it involves a basic understanding of the resources that you have. Whether or not, whatever resources you have, these resources can meet the internal or external demands of the stressful event. So, when I say that I have a system of support, or I have friends who I can speak to, I know that my secondary appraisal tells me that I'll be able to manage this situation. If, for example, my exam has gone bad, the harm that it has caused is that I feel miserable about the exam going bad. The threat is, what if I do badly in other exams also? Challenge is, maybe I may be able to manage those things. So, that is in a nutshell what we've spoken about in terms of stress. How does stress contribute to illness? Let's be very clear. Wherever Dr. Kedar has spoken, wherever I have spoken, we have maintained that stress has a direct impact on physiology. So it is something which will alter our functioning. Any stressful, so I'd like you to take just 2 seconds, perhaps, because we're at a crunch of time. So think of any recent situation which has been stressful for you, right? And just try to think how that impacted your body and your brain. What were your thoughts like around that stressful situation? How did your body respond to that situation, right? So, when we speak about, and as we speak about stressful situations, let's also understand that stress will impact health behaviors. So, what happens is it is going to impact our choices. So, people undergoing chronic stress tend to have poorer health habits. So, these poor health habits look like poor nutrition, lack of exercise, substance use, a tendency to use substance to cope. And again, it has implications for our psychological resources as well. When we talk about the psyche, we're looking at thought processes, we're looking at emotions, we're looking at behavior, we're looking at self esteem. So, an exam not going well, or let's say you're not doing very well in a particular subject, in a particular paper, the thought process around it. So, sometimes the cognitions tend to be I am worthless, I am not good enough, right? Because I did not clear this paper, I cannot do anything. So, thoughts. As a consequence of that, you feel disappointed, angry, frustrated, sad, hopeless, helpless, and an assortment of feelings. Behavior, sometimes we tend to withdraw ourselves. So, things that we would enjoy doing previously, we tend to distance ourselves from. We tend to isolate ourselves. We may not sleep properly. A lot of time may just go on scrolling. It may disrupt our eating patterns. So, a lot of us may turn to food, for example, to deal with stress. Self esteem, your perceived value, and sense of worth. So, let's be very clear about this. Life is going to throw curveballs at us at any given point in time. We may not be able to predict. But our sense of self is far beyond those stressors, far beyond those challenges. And that is what we have to maintain. That is what our anchor needs to be. Who you are, what you bring to the table in terms of your abilities, your strengths, everything that you've learned so far, the experience that you've been able to culminate, how you can use that is something which helps, is something which acts as a safety net. So, if this exam was a tough exam, if this paper is a tough paper, go back to your past experiences, go back to your struggles from the past. How is it that you manage those struggles? How is it that you can step up yet again, make use of your resources, and then move on with life, right? So again, it's the same. The last point is the same point around treatment adherence, which we've spoken about. Some sources of stress, as we've already touched upon, daily hassles, stressful life events. Yes, Dr. Kedar, please go ahead. We can't hear you. I think you're on mute, so you'll just need to unmute yourself. I've done that
I've
for
already
you.
covered sources of stress. So the only thing I'll add to this is the most stressful situation that a person will ever encounter according to a scale is the passing away of your spouse. Very funny because we spend almost our entire day sending each other memes about what our
Dr. Kedar, I'm not sure if it's
source of stress actually most in the
so I'm not sure if
all right.
it's your network, sir, or
Interesting how social support works.
yours.
Next slide, please.
Yes. Coping and resilience.
Yes, the coping and resilience. Now, coping and resilience समझने के लिए first you have to understand the difference between coping and resilience. Toti, if you can move to the next slide and talk us through it.
Yes, so coping and resilience, like Dr. Kedar said, the basic difference that we need to understand, let's simply understand resilience as the ability to bounce back, right? Imagine a basketball hitting the field and bouncing back. That is resilience for you, simply put, right? When we speak about coping, coping involves using strategies to manage the demands of a particular situation. It helps us reduce the negative impact that the situation may have contributed towards, and coping is a dynamic process. It is not something which is fixed. So ऐसा नहीं होता कि अगर आपने कुछ एक चीज यूज करी है, that is something which is going to help you always, right? So the whole perspective has to change around that. So it's a dynamic process which includes a set of responses which you gather over a period of time, right? And ये समझना बहुत जरूरी है that it may have helped in one situation, right? So sometimes when people tend to resort to avoidance, so a lot of us tend to avoid situations, right? Avoidance may help you at a particular point in time for a limited period of time, right? However, it is something which is not going to help long term. Okay, so that is a basic demarcation that all of us need to have, that it is dynamic. It involves various things: your personality, how you think, your thought processes, your strengths, your appraisal of your strengths, your knowledge around how you tend to react, and a lot of other things, your belief system, right? So, all of those things put together would come under the purview of coping. When we talk about types of coping, let's understand this in two broad categories: problem focused coping and emotion focused coping. So, problem focused coping, as the name suggests, you're targeting the problem. You're looking at decreasing or eliminating the stressor, whatever is causing problem, आप उसको directly target कर रहे हैं. So you are generating solutions for a particular problem. So if you're struggling with a particular paper, maybe we get in touch with the teacher. We study with our friends. We look at different ways of studying. What is your learning style? What is it that can be accommodated, perhaps as a new learning method, something that helps you prepare better? Problem focused, right? So you are employing a strategy where you're targeting the problem. Emotion focused coping, again, as the name suggests, where you are looking at regulating your emotions. We are human beings, we will get impacted. Stress will have a response, right? So that response can also culminate to the level of our emotions, how our emotions can be a little difficult to deal with sometimes. So the individual is trying to regulate their emotions by using some cognitive and behavioral tools. What do these tools look like? Focusing on your thoughts, restructuring your thoughts. Instead of just holding on to one perspective, a linear perspective, becoming multidimensional, understanding different vantages, seeing are there any cognitive distortions. कभी कभी क्या होता है that we tend to think in terms of black or white. Sometimes we may make overgeneralization. So one exam going bad, I am a failure. Overgeneralization. Somebody said something, you personalize it, that oh, this person would have said something to me only, right? So those kind of things are cognitive distortions, where what happens is that we tend to have inherent biases in our thinking. तो हम सिचुएशन को जैसी वो सिचुएशन है वैसे नहीं देख पाते हैं. We're not able to see the situation as it is. We're not able to appraise the situation for what it is. We approach it with a particular lens, and that in itself is a biased lens, right? So the nature of a stressful event to a large extent determines the choice of coping strategy used, which is why we say it can't be generalized. It's very dynamic in nature, right? So there is self management that we do, there is situation management that we do. So self management, taking care of your cognitions, your emotions, your behaviors. Situation management, when you are able to address the stressor, जब वो आपकी अपनी लिमिट्स में है, आपके दायरे में है, आपके पर्व्यू में है, for you to work on. So
Oh,
this
wait,
is
this one's mine. This one's mine, isn't it?
yes.
Problem focus versus emotion focus. We'll look at both the examples, and this is a case discussion, which is my experiences with the tooth. All right, literally my experiences with the tooth. So we are going to talk about a psychiatrist who had a dental phobia to the extent that he could not get a root canal completed, courtesy of which, as dentists tend to do, he dug up 4 or 5 places and left it ajar because I couldn't go for follow up. I was scared of the pain, like I told you. And I was not sure of what to do. But the solution presented itself when I went to someone who had just passed out, who was aware of what dental phobia was. And what she did on the first day was she sat me down on the dental chair. And this is my sister's friend, whom I have known since I was a kid. Imagine, I only had to wait her to become a dentist. That is like 25 years before I would took treatment from her. But she sat me down on the chair and she gave me a goggle and she gave me headphones, which did not play anything. But what it did was it diffused the amount of exposure that the dental chair throws at you. So the sunlight got muffled, the light got muffled, and the voice got muffled. The whirring sound, which creates the anxiety, got muffled, because of which I could sit down and finish 2 root canals in one sitting. Problem focused coping strategy. happened because people were actually bothered enough to realize that it is the anxiety of the sound, which is nothing more than a whirring of a machine which throws water at you. It can't hurt you, but it is the sound and the phobia which creates that issue. It reached a stage where I required implants, and I told her there is no way I'm going to get my implants done in one this thing. So I want all five implants done in one procedure, and she said not possible. I said let's try. So I went there. She gave me a proper goggle, this thing. I took a clonazepam and I sat through the procedure for 1.5 hours. Implants done. 15 years of going to the dentist, running away, scared. My mother will still tell you stories of how I ran out of the dental chair. Done. Treatment completed. Quality of life improved 1,000-fold because someone was smart enough to realize that it is the voice of the thing that helps, and it is the glare of the lights which needs to be reduced. So problem focused coping helps. All right. Coping outcomes, well, you should actually look at these things when you're trying to figure out how to cope better. All right. How you can reduce stressors, how you can build distress tolerance, which is what I'm talking about, achieving emotional regulation, and enhancing prospects for recovery. All right. So that is something that we actually tend to focus on when we are looking at coping mechanisms and coping outcomes. Next slide, please. Oh, just one second. Thank you. Thank you. That was my son. Oh, go back. One slide. Yeah. Case discussion important for one simple reason. Emotion. That's my son. Can you give me a minute? So they just
Till
talk them through the next two slides.
yes.
The next two slides for me. Talk them through the other ones. Next one,
So
please.
till you join us back,
I'll cover this one and cover the.
right, I'll just cover the lifestyle factors. So here, when we're talking about some factors affecting illness, we have very common factors that we see and we hear about: alcohol use, nicotine use, obesity, eating habits, sleep hygiene. So these are things that we come across very commonly. What we need to understand here are that these are some general universal factors that tend to be there. How they affect illness basically is how our poor health habits will have an implication for our behavior and the choices that we make. So eating patterns which are disruptive, skipping meals, eating food which is high in sugar, and so food which is not so healthy, something which your mothers are going to run after you for. So those things, of course, precipitate a lot of stress, which can have consequences for illness. Dr. Kedar, would you like to run us
Yes,
quickly
yes,
through the?
yes. So a couple of things. We all know these are problematic factors. Like I pointed out, when you talk of health psychology, anything which is in excess, there are people who are trying to take coffee cups 4 to 5 and complaining of anxiety and worsening of the symptoms. That needs to be treated. You need to figure out which behavior needs to be modified. There are times when a cardiologist will refer a person for nicotine de-addiction. All right, tobacco and cigarette, they are taking 2 to 3 packs of cigarettes a day and they need to stop. How do you do that to ensure that the angioplasty or the intervention that has been done doesn't go waste? That is down to you. Bariatric surgeons who refer patients for controlling of their impulses for food habits, because after a bariatric surgery you still have to control how you eat, and even more so because you have to be aware of it. That matters. Sleep hygiene, the most common simple thing that is there but is often overlooked. How we sleep affects the next day and our daily routine, and people will take the wrong medicines for it. These are all lifestyle factors, not to mention alcohol, because the number of people with alcoholic liver disease who still insist on taking the alcohol even though they have been told कि एक और peg आपके लिए poison की तरह है, these people will keep on coming back if you don't intervene. So we actually in our hospital have created a checklist to ensure that if this is one concern, the counseling psychologist gets involved at the grassroots level for treatment and counseling. So these are the lifestyle factors which affect illnesses. Not to mention sugar cravings. One sec. Sugar cravings. Not to mention other things like coffee in anxiety or cardiac conditions, which will take effect. All right. Go back a slide, please. I'll take 2 minutes on this one because I'm very proud of what we are about to discuss. See, I told you that rheumatoid arthritis and rheumatic diseases have are one of the primary psychosomatic illnesses. We have a wonderful rheumatology department headed by a person who is very aware, Dr. Kaushik Bojani, of how psychiatric interventions help. And he, for one, will ensure that the team, the entire team, the psychiatrist, the psychologist, is involved in conversations. So I'll give you an example of what helps at the least possible expectation. Okay. We were called into the ICU to talk to a patient who had Sorgen's syndrome. Sorgen's syndrome is one of the cases where there is a lot of loss of your muscle mass. It's a very, very poor prognosis. And they could not understand why the stats were not improving. The call was simple. We don't understand what to do. We don't understand how to talk to her. Every time we give an antidepressant, there is a side effect. Someone help. This was the call from the RUMAT team. And we went there and we started having a conversation. We found an antidepressant. Okay, it's Sorgen syndrome, guys. Sorgen syndrome. All right. Uh, it is one of those situations where the prognosis is guarded, the patient is aware. But the antidepressant can't be increased because the side effects would interfere with the treatment. So I started her on antidepressant. And after that, 2 days later, I introduced her to an art based therapist and a counseling psychologist, both of whose only job, was to go there and talk to her about things that she can do on her daily basis. And what we found to our surprise was that she liked to read. And both of us, that is me and the patient, remember, the art-based therapist was not actually aware of the novel, were fans of Frederick Fawcett. We like to read Frederick Fawcett novels. So I started having a conversation with her on a daily basis of what the novel she was reading on was about. I think Fist of God ya kuch to tha. And she started showing signs of taking interest in things. This was at the lowest dose of antidepressants. Eventually, she started doing the activities that the art based therapist asked of her, and the counseling psychologist told her. A story of resilience developing because there was a common thread that she could latch on to. There was something that she could look up to. I always say this because it took around 10 people to find a common ground with the patient, and it helped. It was the entire team. There was a similar story I had read in Chicken Soup for the Soul 20 years back. A child with a very poor prognosis was brought into the ward and treated. And the only difference was there was uh, a help who would read to him about what was going on in their school. And the child started responding well. And the question the help asked was, how do you respond so well? And he said, I don't know what's happening, but I'm fairly certain that if my prognosis is poor, no one will bother teaching me my daily routine. So people will latch on to that ounce of hope that you give them. It is for you to figure out where it comes from. And this is where health psychology matters. This is where that common strand needs to be discovered so that you can give them something to look forward to, a small hope, even when things are bleak, to hang on to, a conversation to look forward to. Yes, it was Frederick Fawcett, but I'm telling you again, it was a patient specific conversation. अभी मिल्स एंड बून्स होता तो शायद मैं नहीं बोल पाता. I would have figured out someone else who did that. All right, next slide. Social support as a supportive factor or protective factor, extremely important. I'll just give you one example. For my thesis, I um, uh, did a research work on psychological distress in, of all the places, pregnancy. Why? Because my father is an obstetrician and gynecologist. And what we found out was that the anxiety and depression worsened when the perceived partner involvement came down. If the spouse was not interested, the anxiety and the depression of the pregnant woman tended to worsen. We are not talking of whether she was married, unmarried, help or no help financially, how she was doing. This was related to the perceived partner involvement. How involved is the husband or the caretaker in that pregnancy? So this is the importance of social supports. Of all the places it came from, pregnancy, something we would never have thought about. Okay, I thought I would share this with you. Stuti, yours.
So, social support, again, not very difficult to understand. We'll quickly try to synthesize it, which is however you can assist people, however you can extend yourself to comfort people. And support does not always have to mean tangible monetary support, it can also be intangible support. Right. So depending on what the nature of the concern is, so you running like a small errand for a colleague, for a friend, for anybody or everyone who you may come across who may be struggling, that is also support. Just listening to somebody with genuine empathy, being there for someone, giving them that sense of comfort also qualifies for support. So, support is not something which has to look very fancy. Support is not something which has to be very flamboyant, nothing like that. It is something which can be derived from our most immediate interpersonal relationships. It can be in the form of practical help, tangible support, as we spoke, in terms of resources, in terms of what chores, what sort of a help you can extend practically, and intangible support in terms of being there for people, giving them that sense of conviction that they matter. You don't always have to, offer advice. Just sitting there with somebody who may be struggling, just allowing them to feel whatever they're feeling and directing them to the right sources of help is support, right? So, effects of social support, of course, something that we don't have to speak about at length, but what research tells us is that it lowers the likelihood of illness, speeds up recovery from illness, and it is something which acts as a protective factor, is what needs to be emphasized. As a part of this, we also, when we talk about health psychology, we cannot miss talking about support groups. So what are support groups basically? It is a collective platform, right, where people, it enables people to share concerns which are shared concerns. So support groups for cancer patients, where you are getting a collective platform to talk about concerns which are shared mutual concerns. Now, these groups serve as resources. So, a lot of people may not have access to social support. So, support groups become that matrix for people. Specific information is disseminated, specific, factual, accurate information with respect to how they can build their resources, how they can cope with the illness, how they can adhere to treatment and manage things along the way is something that support groups are for. And additionally, what is also important for us to emphasize at this point is how caregivers are also a very important part of the ecosystem. So it also involves working with caregivers and families by psychoeducating them, by managing caregiver fatigue, which is very common in chronic illness, right? So those are some things which we look at when it comes to support group. Another relevant topic for us to address here is quality of life. Quickly, as we're heading towards the end of our session, these are some topics which are important from the paradigm of health psychology. When we talk about quality of life, so the World Health Organization defines quality of life as an individual's perception of their position in life. Basically, it involves looking at various paradigms. Some of them are right in front of you: physical functioning, psychological status, level of independence, social relationships, environment, spirituality, religion, personal beliefs. So basically, how you are doing physically, what your physical status is in terms of uh, what kind of stressors or illnesses, like the kind of impact that it may have on your body, right? Psychological status, how you're dealing with the illness at a cognitive level, how your emotions are in play. Then level of independence, the kind of mobility, if there has been any disability around the illness. Social relationships, again, the level of social support that tends to be there. Environment, whether or not it's a conducive environment for recovery, treatment, again, everything which is to do with the socio-cultural aspect of this, and your personal beliefs are what come under the quality of life. Now, Dr. Kedar, would you like to speak about promoting health and well-being?
Yes, absolutely. But before
Yes.
that, I'll talk talk something about quality of life. See, quality of life will be affected for the patient and the caregiver both. The number of people who come to me now, forget health psychology, even for psychiatric illnesses, agoraphobia treat kiya, so the person was able to travel and take his family outside the state because the fear of traveling on trains and flights reduced. The quality of life improved not just for the person, it improved for the entire family. You could take the promotions. So you don't know which intervention will help where. All right. We're going to talk about a very important factor, that is the cultural diversity issues and how they affect promoting health. We have already discussed this a lot. We have discussed how the patients think, what the go to factors are, what are the problems, and how we need to inform them about this. A language which is easy to understand for the patient and which they will realize what is happening in a way which is relevant to them is absolutely crucial. So cultural issues may play an important role in how the patient perceives the intervention. If you word it wrong, the patient will perceive this erroneously and not take the intervention. All right. And you have to target the right population group at the right time in the right way that we are discussing. Next slide, please. There is an important part of cultural part of promoting health that we have to discuss, and this is quite frankly idiom of distress. All right. I don't know if it's been covered, but this is a very important term. Idiom of distress is a physical symptom or a situation which a person will say when they are going through psychological distress. Okay. Towards Mumbai in the south regions, you get this commonly as headache and pain. If someone comes to you without an explanation, wondering a pain which is not explainable, most of the times it is psychosomatic in nature, and the treatment is an antidepressant because it's an idiom of distress. This is their way of saying ki I am concerned, I am scared, I am anxious. They can't do this because of cultural factors. Okay, in the south it is pain or headache or fatigue. In north it is dissociation, anxiety disorder, anxiety situations, anxiety scenarios in which dissociative trances tend to occur. So remember, idiom of distress will be very peculiar to your community. And if you treat it as a physical complaint, you will end up doing all the wrong tests for all the wrong reasons repeatedly. And we see this very commonly in our day to day practice. So be careful of idioms of distress and figure out which ones of these are there in your community. Right? Conversations at cultural levels need to happen on a regular basis, and you should be aware of the terms used. Thanks. Right. So promoting mental health and promoting health in general, well, why is it important? Because that's the best thing we have to try and pick people up sooner, quicker, and with effective intervention possibilities. All right. It also gives the chance of normalizing the stigma, reducing the stigma, ensuring that the response is better. It gives you the best chance of ensuring that the treatment you're going to give is going to be received well, taken completely, and the person is going to recover from it. And for that it is important to promote the mental health with the right population, with the right understanding, in the right ways, with the right tools. Social media is a great tool. You need to use it to the optimal, but some interventions have to be tailored according to the situation. Example, dots. Specific population groups, the target may not be the patient themselves, like children, it may actually be the parents. Specific population groups, you may need to intervene 2 years early because they will develop into high risk population groups. Example, adolescents when they move into that puberty age group. All right. So you need to be careful and you need to assess the risk and establish the support environments, destigmatize it to help. Next slide, please. Okay. There are
Just one point
some.
that I want to add, Dr. Kedar, when it comes to promoting health and promoting health and mental health, one thing that we need to take into account is that we need to go beyond the health sector, right? So we need to incorporate practices in sectors like education, labor, workplace, and a lot of other sectors that we can look at, because it's not just relevant in healthcare, but it's something that we need to look at from a 360-degree vantage, right? So when it comes to child and adolescent mental health, it can be achieved through school-based programs. And when it's about mental health at the workplace, how interventions can be tailor-made for employees, for the working personnel, something which aims at optimizing mental health at the workplace, right? And then we come to help seeking behaviors. Please, Dr. Kedar, go ahead. This is our last uh,
Last
segment.
slide, is it? Yeah, yeah.
Yes.
So you have to build awareness and appraisal of the problem at an individual level. You have to try and ensure that they get the facts right, they get the correct information. There is no stigma about it. We've all seen this when COVID happened, so you are aware of what we are talking about. You have seen this at a personal level. You have seen the sort of um, disorganization, the sort of absolute chaos that happens when certain things are interpreted the wrong way. So it's absolutely essential that you get it right, and you get it from the right source, you get it from the right profession. All right. You have to build at an individual level the awareness of the intervention, the source of the information, the authenticity of the source. That helps. Institutions and organizations have to make it obvious about what are the best options available, what are the treatment gaps that can be reduced. They have to try and ensure that the scale of access to mental health uh, increases very quickly, and the bridge has to be reduced as soon as possible. All right. Adopting practices which promote equitable and inclusive systems help, because remember, in the end, we will heal as a community. It's extremely important that we do this. And if this is the only learning that we get from, let's say, a big pandemic like COVID, it is that there is a collective us and we can heal together as a community, then that should be it. And these are the levels that we should target places at, situations at, scenarios at. Health psychology has an important role to play. We've all seen it in COVID. We have seen it on day-to-day basis. We need to be aware and alive to what we can do to help them move forward. All right. Next slide, please.
So that would be all. And perhaps just as a closing statement that I'd like to add is that we stick to the fact that we cannot define health without mental health. And owing to that, taking that into account, that serves the foundation of health psychology. So putting health and psychology together is what we do, and is what needs to be done at different levels, right? So that has been the interface of these two things coming together. So these are various social media platforms that we have, where everywhere you will find us everywhere, right? So Instagram, Fortis Mental Health, Fortis underscore MHBS, Snapchat, and Fortis Mental Health on Facebook. We have a WhatsApp channel and a YouTube channel by the name of Fortis Mental Health. And you can write to us at mentalhealth@fortishealthcare.com. And of course, there is our WhatsApp number, which is 9811806117. There's a stress helpline that we have available in 14 different Indian languages. And feel free to reach out to us. This is something which you use to unmute yourself. We are there to listen to you. We're there to be there and to help you, right? So 83768040102. And that brings me to the end of our session for today. A big thank you to each one of you for being present, for taking out the time, for associating yourself with the cause which goes beyond self, of educating yourself, building awareness around mental health, because that is what we need. Each one of us are stakeholders in this process of breaking stigma, of making help accessible, and by building the right kind of ecosystem, by building awareness, by doing what we can at our individual levels. You being here today is a testament to that. So thank you for being there. And over to you, Dr. Kedar, on a parting note.
Yeah, very important announcement, guys. That link has been posted. Voice call from plus
Alright.
91. So, if you want to check your this thing, a lot of you are concerned about the link. The link has been posted twice now, so you can click on it. Your assignment links. The assignment has been prepared by Stuti ma'am. So if it is too difficult, she'll give you the answers tomorrow. Don't worry about it.
Find out the
All right.
secret, which is not good, Dr. Kedar.
No, it is not. I read the questions. They are tough, but the answers are easy. All right. So don't
Yes,
worry about it. Yes. Okay. I
right.
will take questions here since people are asking. Sir, is there somatic? Is the somatic location involved have some direct relation with specific distressing symptom? Somatic location involved. I'm assuming you're talking about where the pain is. The answer would still be the same. If there is a biological basis for the pain, it is not considered psychosomatic. But if there is no other explanation and it distresses you, then it becomes a psychosomatic concern. Interestingly, one of my professors, a person whom I respect very much, used to say that there is one location in your body where the pain will not come unless you have been hit. So he used to always ask psychosomatic cases, okay, whether you have pain, can you guess the location? At the tip of your nose. That is to say, of all the places in the body, if the pain is at the tip of your nose, it fits into psychosomatic concerns. You can actually go ahead, just ask you or कोई trauma नहीं हुआ है. All right. Um, According to theory, knee means resistance to move forward. Oh my God. Yes. Oh, by the way, Freudian concepts, even though I actually did read a little bit of Freud during my psychiatry, are now frowned upon because of the advent of honestly MRI and CT, where we have found better explanations for what happens. And if there is any psychological stresses, counselors will pick it up after all the medical reasons have been ruled out. Remember, psychosomatic conditions are the last reasons in your book. If you miss a diagnosis, the patient will continue having and pain. Yeah. Now, there was one question I had asked you, and I promised you guys that I'll answer towards the end of it. Can you tell me the can you tell me the psychological factors which will be seen in a radiology ward? Right? And the answers are these: pseudopsoriasis, look it up. Okay, pseudopsoriasis and pseudotumor cerebri. Look these conditions up. These conditions will actually be picked up when there is a radiology reference, but are psychological for treatment, psychiatric for treatment. Oh, and by the way, since we are talking about this, there are actually patients who have refused life-saving MRIs. जिसमें diagnosis confirm हो जाता, they refused to go in because get it, they were scared of going into the MRIs. So giving them a clonazepam, giving them an injection to reduce the anxiety, allowed them to go do the MRI and come out and get a surgery which should have happened 6 months back, पर उन्होंने किया नहीं था क्योंकि they were scared of going into the MRI. So anxiety also precipitates. Yeah, health psychology we can keep talking about as we go and go. Yeah, Deepika is the person you should look at. She's getting most of the terms right. Are there any other questions that we have missed? Can we just look through this once? Are there other qualification courses, Tuti, for becoming a health psychologist?
So we're looking at a master's and like a further specialization, perhaps in terms of a certification, is what you could look at. And again, my knowledge here in this is limited, but this is something that we'd get back to you. So feel free to reach out to us personally, and would be more than happy to build awareness around that and get back to you about it. So the most basic prerequisite would be a master's.
Someone asked opioid agonist therapy, what sort of treatment is that? It would usually come into pharmacotherapic interventions given by a psychiatrist. Right? Why? What does a health psychologist do when child says that he is having stomach ache and other things like that just to seek attention of parents, teachers, or peers? Tuti, this was meant for you.
But thank you that you read it out, Dr. Kedar. So again, as a health psychologist, in the capacity of a health psychologist, let's try to understand that that is what we see. Why that happens, what we do not see is what we have to start seeing. Why is the child throwing a tantrum? Why is it? What is it that makes you say that they're doing this for attention? Is also something that you need to look at, right? And you speak to the child, get to know them better, understand what they're here for, and what is it that their struggle is all about, right? So have a full 360-degree understanding of that, and not just that attention seeking behavior. What makes you want to call it attention seeking behavior is what we also need to reflect on as psychologists, right? So there lies your answer. So look at everything in totality and not just one behavior that stands out,
Yes,
right?
and always after a pediatrician has told you that there is nothing to do here. A
Yes.
lot of you are also asking if observerships can be handed out. Well, the person you should be buttering up for that is Dr. Parik sir when he comes next. All right. He is the person who will tell you whether you can do the observerships or no and why we may or may not be able to do it. But he's the best person to reach out to. Or Kamna ma'am or Divya ma'am when they come up. All right. What about hypochondriasis? Well, what about it? It's a mental health condition. It's treatable. You figure it out. You do the assessment. You figure out how much insight is present, and you treat it accordingly. Illness, anxiety disorder with delusional insight, hypochondriasis with delusional insight are serious conditions where you need to identify, need to diagnose, and treat. But always treat with the understanding that any somatic symptom that a person presents with can be actually physical. And when that happens, you should have your paranoid ideations clear कि हालांकि डायग्नोसिस हाइपोकॉन्ड्रियासिस है, ये फीवर का रीजन मलेरिया हो सकता है, and every somatic symptom has to be ruled out on a medical basis. That is something that we always do. We always work in liaison with a medical team, purely because every person has the right and at some point of time will actually fall sick. So you need to rule out medical illnesses. All right, guys, it's 6:15. If there are other questions, we can answer it. Otherwise, thank you for being a great crowd. हेल्थ साइकोलॉजी पे 3 घंटा सुनेंगे ये मुझे लगा नहीं था ऑनेस्टली. आई थिंक देयर इज होप फॉर अस येट.
Yes, absolutely. That is our motto and our saving grace at the same time. Right.
Yeah, true. Right. Thank you so much.
Thank you.
Um,
Yes, thank you so much, both Dr. Tilve and Mr. Sood. We had a wonderful session. Like always, it's a pleasure to hear from both of you. And thank you for the wonderful session. And all you guys, the assignment link, the attendance link, both has been in the description box, so you can avail it from there. I thank the speakers one more time, and I'll see you all guys tomorrow, same time.
Thank you.
So,
Be
bye.
well. Okay. Bye bye.
bye, guys. Stay safe.